Good morning, ladies and gentlemen, and welcome to the first E3 International Cancer Conference here live in Kigali. I want to welcome you all. My name is Walter. I'll be your host, and today I'm so privileged. I'll be hosting this conference with my co-host called Dr. Ndoli. Dr. Ndoli is an oncologist in the military hospital here in Rwanda. Dr. Ndoli, can you come? Can we give a round of applause to my co-host, Dr. Ndoli? Dr. Ndoli, welcome to the program. Can you tell us and greet the people, and we continue.
Thank you very much, Mr. Walter. Good morning, everyone. So while welcoming people, we usually welcome them in my native language. Do you know how they say welcome?
What is your native language? I don't know. You can tell me so that I know what's your native language?
Please guess.
Rwanda.
Oh, yeah. So he knew my native language is Kinyarwanda. So in Kinyarwanda, they say murakaza neza.
So when you say murakazaneza, how do I respond to murakazaneza?
Maybe if you can tell the people murakazaneza and you get their response. What if we do that?
Murakazaneza. So welcome, thank you so much, murakazaneza. Then we say murakoze chane. Murakoze chane is thank you. So ladies and gentlemen, we just want to run down the program today, and we are so privileged to have this conference here at ICAD, a center where we are going to be deliberating a lot of topics, and we are here. Without further ado, I just want to, you know what's going to happen, Dr. Ndoli? We have a great day to call upon the next speaker. And I want to tell you the profile of the next speaker to give us the official welcome remarks. The welcome remarks, we have got a distinguished chartered accountant, an entrepreneur, driven by the passion to foster the ongoing culture of improvement. This person, he's in the building. He is the group managing director of JKK and also the managing director of E3 International. Is amongst us. Ladies and gentlemen, this speaker, his profession shines mostly in the realms of freight and event management in the industry, where he has implemented successful strategies to boost operations, profitability, and performance. He's particularly adept at organizing tasks, setting priorities, and delegating duties to achieve safe delivery goals. Moreover, this speaker, ladies and gentlemen, allow me to tell you the presence of JKK and also E3 International Conference is in the countries like India, UAE, Africa, USA, and E3 International Limited, it focuses on four main things: event organizing, trade shows, trade delegation, conference, and exhibition like this conference. Ladies and gentlemen, help me to welcome Mr. John Koshi to the stage. He's the group managing director of JKK, and also he is the managing director of E3 International Conference. Help me, ladies and gentlemen, to welcome Mr. John Koshi to the stage to give us welcome remarks. Mr. Koshi, to the stage. Can we give a round of applause?
Good morning, everyone. Dear Director General Professor Claude Muriveni, representing Ministry of Health, Rwanda. Dear Dr. Brian Chirombo, country representative representing World Health Organization, Rwanda. Dear Professor Jack Maresco, President and founder of IRCAD Africa. Distinguished participants, ladies and gentlemen, good morning once again. John Koshi is my name, Chief Executive Officer of E3 International Limited. It is with immense pleasure and a profound sense of purpose that I welcome you all to the first edition of E3 International Cancer Conference, where we gather under the theme of Bridging the Gap, advancing cancer care, research, and education in Africa beyond post-COVID era. In these unprecedented times, as we navigate the complexities fashioned by the global pandemic, it is more crucial than ever that we come together to address the pressing challenges facing cancer care, research, and education in Africa. The theme of our conference underscores the urgent need to build bridges, bridges that connect us, bridges that transcend boundaries, and bridges that lead us towards a future where cancer is no longer a death sentence, but a conquerable foe. Africa, with its rich diversity of cultures, landscape, and people, present both unique opportunities and formidable obstacles in the fight against cancer. Despite the remarkable progress made in recent years, much work remains to be done to ensure equitable access to quality care, to drive innovative research, and to empower future generations through education. As we stand on the precipice of a new era, one marked by resilience, adaptation, and renewal, let us seize this moment as an opportunity to chart a bold new course forward. Let us harness the lessons learned from the COVID-19 pandemic to strengthen our resolve to foster collaboration across borders and to accelerate progress towards our shared goals. For too long, cancer has exacted a heavy toll on the people of Africa, robbing families of their loved ones, undermining economic development, and perpetuating cycles of poverty and despair. But today, as we gather in this virtual space, I am filled with optimism and hope. I see a vibrant community of stakeholders, from clinicians and researchers to policymakers and advocates, united in their commitment to effective, positive change. I see the seeds of innovation taking root as new technologies and approaches emerge to revolutionize cancer care. And as I see a shared determination to ensure that no one is left behind in our quest for a brighter, healthier future. Over the course of 2 days, I have no doubt that our discussions will be lively, our debates spirited, and our insights profounded. But let us never lose sight of the ultimate goal, to transform the landscape of cancer care, research, and education in Africa and beyond. In closing, I extend my deepest gratitude, each and every one of you, for your unwavering commitment to this noble cause. Together, we have the power to change the course of history, to rewrite the narrative of cancer, and to create a future where we hope triumphs over despair. Thank you, and may this conference be a source of inspiration, collaboration, and hope for us all as we look forward to make this event an annual event in Rwanda. Thank you once again.
Thank you very much, Mr. John Koshi. Allow me to welcome our next speaker, who is going to be joining us virtually, Dr. Monirul Islam, who is the chairperson of the scientific committee. I think if he's online, we are going to have him next. I just wanted to remind us our theme of today is Bridging the Gap, Advancing Cancer Care Research and Education in Africa beyond the post-COVID era. So our discussions today and tomorrow are going to be around this theme.
Good morning, everyone. Can you hear me? Hello?
Yes.
Hello, everyone. Good morning. Greetings on behalf of the Scientific Committee of the E3 International Cancer Conference in Kigali, Rwanda. My name is Dr. Monirul Islam, and I led the scientific committee of this conference. The committee was involved in the initiation, development, plan, and assessment of all scientific needs of the conference. The committee also identified the speakers, panels, and review abstract for this conference. Let me take a few minutes time emphasizing the rationale why we picked up the cancer conference in Rwanda in Africa. As you know, the cancer disparities are prevalent across the globe. But some regions experience disparity far greater than others, and African continent fall in this category. We know the country with low human development index score are more likely to experience a higher burden of infectious diseases, but at the same time, due to globalization, these countries are experiencing the burden of chronic disease, cancer, as well as at the same time when it is also taking the burden of infectious diseases. As you know that according to the UN, 33 of the list out of 45 least developed countries are on the continent of Africa. This is based on 2024 data. According to 2020, South Sudan had the lowest human development index score. At the same time, if you look in one of the North American country like Canada, which had 0.93. If you look at the European countries like Switzerland, Denmark, Norway, Finland, they have 9.6. The reason we are here gathering today to emphasize that there is a greater need for cancer research, education, care, innovation in African continent. Cancer was the 5th leading cause in Africa in 2020, and it was responsible over 700,000 deaths in the continent. Whenever we compare two countries or two regions about the disease burden, we always try to compare utilizing 8 standardized incidence rate, mortality rate. As you can see, as I'm trying to give you two very fundamental numbers. If you look at these data, African continent on average, there was 132 cancer death per 100,000 population. At the same time, there was 88 deaths per 100,000 population. If you look at the data at the same time in North America, the cancer incidence, age-adjusted incidence was over 3 times, which was 365. But the mortality rate was same, 88 per 100,000. So there is a big disparity in cancer mortality between the developed and developing countries. You might ask question, why this higher mortality between these two different economically society? Because the individual we diagnosed with cancer in developing countries, more specifically to African continent, either do not receive adequate treatment on time or being diagnosed at the late stage and do not respond to the treatment. So this is the current status. We have very similar cancer deaths or mortality when we have only 1/3 of cancer incidence compared to the developed country. Imagine from now on in next 5-10 years, as you can see that the economical development in the African continent and human development index are improving. That translate into less infectious diseases, more life expectancy, and we expect higher incidence rate in this population. If we cannot address or try to intervene by screening or early diagnosis and providing quality care for cancer, the mortality rate would be double, triple in next 10-15 years. So let us work together in coming years to address cancer care, research, and education in Africa. That is why we are here together. We are together in this fight, and we are very optimistic that we will win the fight against cancer in coming years. Without further due delay, I welcome you and enjoy the conference and the beauty of city of Kigali, Rwanda. Thank you very much for your attention and have a great day. Enjoy the conference. Take care. Bye-bye.
Thank you so much, Dr. Islam Munrio Islam, who is also the chairperson of the scientific committee. We thank you so much. Without further ado, ladies and gentlemen, it's our singular honor to invite to the podium Professor Claude Mambo Muvunyi, who is also the RBC Rwanda Biomedical Director General, to the stage to give us the official welcome remarks. Please, thank you. Let's give a round of applause to Professor Claude Mambo Muvunyi to the stage.
Good morning. I have to say I'm not Professor Muvunyi. Maybe I will be closer to him in the next years. But he couldn't make it because of another urgent meeting, and then I'm here to represent him. Myself, I'm Dr. Albert Ishime. I'm the head of Diseases Prevention and Control Department at the Rwanda Biomedical Center. And it's a pleasure for me to be here in this conference. Dear Dr. Brian Chilombo, dear Professor Jacques Moresco, dear John Koshi, leaders of different institutions here present, distinguished participants, ladies and gentlemen, good morning again. It is with great honor and privilege that I welcome you all to the E3 International Cancer Conference here in Kigali, Rwanda. As we gather under the theme, Bridging the Gap, Advancing Cancer Care, Research, and Education in Africa beyond the post-COVID era with data, we are embarking on a journey of collaboration, innovation, and dedication towards a common goal of enhancing cancer care across the African continent. As you all know, today the world is facing an increasing burden of cancer diseases. If you look at the recent estimates, released by World Health Organization back in 2020. There were 19.3 million new cancer cases and 9.96 million cancer-related deaths. This is a significant increase from the figures of 2012. Therefore, we have to act now as the cost of inaction is very high. In the wake of the COVID-19 pandemic, the world has faced unprecedented challenges, magnifying existing disparities and exposing vulnerabilities within healthcare systems globally. Despite these challenges, our resilience shines through as we come together to address one of the most pressing health concerns of our time, which is cancer. The theme of this conference underscores the imperative to bridge the gap in cancer care, research, and education in Africa. With the focus on leveraging data-driven approaches, we should be aiming to not only address the immediate needs of cancer patients, but also to pave the way for sustainable, evidence-based strategies that will shape the future of oncology on our continent. Africa is a continent of immense diversity with unique healthcare landscapes and varying levels of access to resources. Yet, in the face of these diversities, lies an opportunity for collaboration and mutual learning. By harnessing the power of data, we can identify common challenges, share best practices, and tailor interventions to the specific needs of each community, and thus ensuring equitable access to high-quality cancer care for all Africans. During this conference, we should be aiming to engage in insightful discussions, exchange groundbreaking research findings, and forge meaningful partnership that will propel us towards our shared goal of a cancer-free Africa. From innovative treatment modalities to cutting-edge research methodologies, let us harness the power of data to drive progress and transform the landscape of cancer care on our continent. We extend our deepest gratitude to all speakers, participants, organizers, and sponsors who have contributed to making this conference a reality. Your commitment to the fight against cancer inspires us all, and we are confident that together we'll make significant strides towards a brighter and healthier future for Africa. We thank you and urge everyone to embark on this journey together with determination, compassion, and hope. I thank you very much.
Let's give a round of applause once again to Dr. Tushimire, who is representing our RBC Director General, Professor Claude Mambo Muvinyi. At this juncture, I want to call upon the speaker who is coming from World Health Organization, Dr. Brian Chirombo. Dr. Brian Chirombo may be still on the way. If he's still on the way, we go to the second speaker for the day. We are going to introduce guest speaker, Professor Jack Maresco to the podium. Can we give a round of applause to Professor Jack Maresco to the podium? Or the representative here present of Professor Jack Maresco. They are going to be joining us virtually online. Let's connect to them virtually. Thank you. Whilst they are still connecting virtually, we thank you so much. To those who are just arriving, we welcome you to this E3 International Cancer Conference, which we are still building up in the theme. Now the speaker I'm hearing that is joining us in the next 2 minutes. We thank you so much to those who are just coming in. We are here at this inaugural, the first ever E3 International Conference. Now, I'm informed Professor Jack Maresco is now online. Thank you. Welcome, Professor.
Thank you very much. Thank you very much, and thank you for this kind invitation. I'm going to speak, because it is an oncology congress, about what we develop in IRCAD France, and especially how we imagine the big change that artificial intelligence are going to transform, to revolutionize the minimal invasive surgery. So that is just a little view of IRCAD France. We start by one building, and now we have 5 buildings dedicated to minimal invasive surgery, especially with oncological application. And we have 2 departments. One is research, and one is training. Since the beginning, when you discuss with a surgeon about how we can improve his procedure, the answer is through what we call augmented surgery. And we work on this topic since more than 25 years now. What is the concept of augmented surgery? The first one is augmented vision, augmented eye. When you discuss with a surgeon, the first thing he would like is to see more than what his eyes are able to see. And that is everything you know, that optical imaging like endocyanin, ICG, but also multispectral, hyperspectral. But we work a lot on the concept of augmented reality. That means how we can see in transparency. For example, if you need to operate a cancer of the liver, how we can see in transparency to avoid any complication. So that is the first augmented eye, augmented vision. The second one is augmented hand, and that is robotics. And you know, when we published in 1998, the first 100 patients operated by a robot, everybody said that we were totally crazy how the robot could replace the hand of the surgeon. But now, we know that we have 136 companies of robotics in the world. And especially we will see a new generation of robots for endoluminal surgery, because we detect in early stage now the cancer of alimentary tract. And finally, we have artificial intelligence, which is involved in all this topic. They involve in the augmented vision, involved sure in the robot, because the next generation of robots are going to be smart robots. So one word about, we need artificial intelligence in each step of surgery. And we know everybody thinks that surgery is just a procedure, how we can remove a tumor. No, the most important thing is one, the diagnosis, and second one, the strategy. So for the diagnosis, what is going to change totally today by artificial intelligence is that we detect the undetected tumors. And you all know for the colon, it's common, because for the colon, you have a lot of systems by Olympus, by Medtronic, which is genius. You see, we can absolutely detect a little polyp of less than 5 millimeters, a plant polyp that is impossible to see with your eyes. And immediately you know if it is an hyperplasia, that means no risk of cancer, or if it is an adenoma. And if it is an adenoma, you absolutely need to remove this adenoma to avoid any risk of cancer. So we know that for colon now it's nearly not a routine, but it's more and more developed in all the country. For the stomach, to do the diagnosis of early gastric cancer, it is absolutely more difficult because the stomach is a big pouch. But you see that today it is possible, especially by the huge development in China. And look, for example, this company, but you have other company. But this company, I think, with approximately 4,000 engineers in artificial intelligence, you see that they are able to do the automatic diagnosis of early gastric cancer, and that the results are absolutely better with the machine than by the gastroenterologist. So you need just to understand that everybody says the machine is just going to be a support for the medical doctor, but more and more the machine is going to replace the surgeon to do the diagnosis, especially to do early diagnosis. And you will see also why it is so important. It is so important because if you do an early diagnosis of cancer of esophagus, stomach, low colon, and rectum, you change totally. It will be no more a normal operation or a laparoscopic operation. It will be an endoluminal surgery. An endoluminal surgery, you will see, needs a new platform, especially a new kind of robot. So after that, we speak about, diagnosis first, how to have the early diagnosis. Secondly, strategy. Strategy is the most important thing. You can perform a fantastic procedure, surgical procedure, but if the strategy is not the good one, it's really the definition of a failure. And what is very interesting, some weeks ago, we had a course, an advanced course of 1 week about rectal cancer and colon cancer in IRCAD. And for this kind of course, we invite approximately between 25 and 30 key opinion leaders. That means the best surgeon in this field in the world. And the last day, always we propose some difficult case. And during the last course, some weeks ago, the question was, you have a young lady of 42 years old. She has rectal cancer, T3NO. She had a radiochemotherapy and the tumor disappeared. What to do? So we have the 3 best key opinion leaders in the world. The first one say, even if the tumor disappears, you need to do a TME, a total mesorectal excision, because there is a risk of recurrence. The second one say, no, you need just to do a full thickness by endoluminal way, transanal way, and a lateral lymph node dissection. And the third one say, no, you need just to do wait and watch, nothing. So in real time, in 3 seconds, we ask the question to ChatGPT-3. In 3 seconds, ChatGPT-3 said, you have 3 proposals. These were the 3 proposals of the key opinion leaders. You can do a TME, you can do a lateral full thickness dissection, you can do wait and watch. But, and that was the immediate conclusion, because the lady is 42 years old, never propose a TME because the quality of life will have a lot of problems. And we know that more than 85% will be totally cured by the radiochemotherapy in this case. So you need absolutely to propose wait and watch. So you imagine that the first machine learning was, if you remember, more than 10 years ago, Watson by IBM. But Watson was $300,000 per year. Today with ChatGPT-4, it is $20 per month. It will be $10, $5 certainly. That means that the patient will have access to ChatGPT. And that means that during the discussion between the surgeon or the medical doctor, the oncologist, and the patient, it will be totally different, because the patient can discuss with ChatGPT 4. And you know also that in New England Journal of Medicine, they have a fantastic article where also the machine was considered to have more empathy than the medical doctor by 100 patients. Why? Because with ChatGPT-4, you put a lot of new keywords you can discuss during 1 hour if you want. With a medical doctor, after 15 minutes, he has no time. So that is why it's going to change. Now, how we use artificial intelligence in preoperative planification. That is so important. Look, this baby, he has a huge hamartoma of the liver. So the pediatric surgeon was concerned about how to start the operation. And you see that if we have a 3D reconstruction by algorithm of virtual reality, we can navigate inside the tumor. And you will see here, we see the right hepatic artery and just 2 arteries going for the vascularization of the tumor. So for the pediatric surgeon, he has just to control these 2 arteries and the operation was totally finished. The same, an example which is very interesting, cholangiocarcinoma of the liver. We show that to our advanced course of hepatic surgery, and all the key opinion leaders, especially all the Japanese teams, they say, oh, this cholangiocarcinoma is on the right side of the liver. You have to do a right hepatectomy for the cure. And when you use the 3D reconstruction, you will see we have transparency, so immediately we have everything. Difficult to understand, so we remove the biliary tract, we remove the arteries, and now we have just the vein. And we see that the tumor is absolutely not on the right side, but because we have an abnormality with no median vein, the tumor is on the left side. And immediately we know, because we can put a virtual crypt, that the operation to perform is just the opposite of the operation plan. That is a left hepatectomy. So just I want also to show you that also a revolution for cancer of the colon, because with a 3D reconstruction, everybody can see very easily where is the tumor, what is the exact vascularization of the colon, where are the lymph nodes. And you see that today we have not to adapt during the operation because we understand everything before. One thing to say why it is important now with artificial intelligence, because we have created a spin-off, which is visible patient, and we are able to reconstruct all these organs before the operation. But the problem is that it was long before the COVID. Look, for example, if we want the reconstruction of a lung cancer, you see that before the COVID, that means 2019, to have the trachea, to have the bronchus, to have the arteries, the vein, it was 4 hours semi-automatic. That means 2 technicians of radiology. And because during the COVID, we gave to the machine thousands of cases of lung anatomy, the machine learned a lot. And you see that in 1 year today, from 2019, 4 hours semi-automatic, 2020, 9 minutes fully automatic, no human resource. Now, 2023, 3 minutes, and we imagine that in the next 5 years, it will be real time. That means automatic real time. That means if, for example, the robot is connected to the PACS of the hospital, in 1 second you push on a button and you will have the 3D reconstruction of the clone, the digital clone of the patient. Another way today is automatic anatomical structure recognition by artificial intelligence. So today we have done only, not for cancer, you see for cholecystectomy. Cholecystectomy is a very simple operation, but 5,000 severe complications per year in the United States. And we know also by the consensus conference that if we are able to have a perfect dissection of what we call the triangle of safety, we have no complication. The machine can understand that. And immediately, if the surgeon wants to continue the operation without a perfect dissection of the triangle of safety, he has an alarm. Or if it is with the robot stops, doesn't want to continue the operation. And now it is a start for cancer, because in Japan, they do the same for automatic recognition of ureter, arteries, vein. But the fact is that in Japan, very often, there are no fats. That means you can see in transparency, so the machine easily can detect this kind of anatomical landmark. The next step is the simulation before the operation. That didn't exist before, but you see, for example, we have 3-4 metastases of the liver to operate. So we know on the computer that we have to do a 3-segmentectomy for the left metastasis. For the other one, we need to do a radiofrequency ablation or cryoablation. And you see that because it is not a 3D CT scan, because it is virtual reality, we can have an interactivity with equipment. We take, for example, the needle, you see, and we know exactly what is the best way to be in the center of the tumors. And we can take all the different instruments. Here, for example, we take the camera, we take the grasper, the scissors, and on the left, we see in transparency what we are going to see during the operation the day after. So that is what we call the preoperative simulation. And now we have the integration. That is the next step, is smart robots. So here it's a rectal cancer operated by the director of IRCAD in Brazil. He was in Strasbourg. It was a complex case. And you see he's operating with the Da Vinci system. So he's totally immersed in the master part of the robot. But he has like a GPS. And you know that today, all the cars, they have a GPS. So it's the same for surgery. It is not the superimposition. It is not augmented reality, but it is a GPS. So he knows all the abnormality of the anatomy during the operation. So that is also a fantastic new step. And the last step we want to arrive to do, but today it's difficult, is the fusion. To be sure to see in transparency, that is a fusion between the preoperative 3D image and the real image you see, which is difficult because it moves. So that is the reason why with Siemens, Siemens will be a huge partner of IRCAD Africa also, and you see that we have elaborated what we call a smart hybrid operating room. So it's fantastic. It is a Rolls-Royce, it is a Ferrari, because in the operating room we have the CT scan, we have the MRI, we have the robotics CT scan. So we can do what we want for hepatic surgery, for example. During the operation, we have the exact anatomy of the vessels, but we need to have the biliary tract. So during the same operation, we can have an MRI. So it looks fantastic, it is fantastic, but it is not reproducible, because this kind of operating room, it's more than $7 or $8 million. So you imagine it's impossible to reduce. So it was a clinical research, which was very interesting, but absolutely impossible to reproduce. One word about a big transformation of alimentary tract cancer. We know that we are going to detect the cancer at an early stage. That changes everything, because that will be the open door for endoluminal surgery by flexible endoscopy. But there is a problem. That's gastroenterologists today, they use an endoscope with the 2 instruments going out of the flexible endoscope in a parallel way. And we know that there is one rule in surgery. The rule is triangulation. If you have not triangulation, you cannot operate. And that is the reason why we develop a lot of prototype, especially with Karlstorff. And today, you will have one on the market. It is an American one. And here it's Professor Xavier Serra-Aracil, chairman of rectal cancer in Barcelona, in Spain. So you see on the ex vivo model, we have a flexible endoscope. We put the endoscope in the rectum, and we can have some, for example, ESD, endosubmucosal dissection, but we can do everything. We can do also a suture. So you imagine that is a revolution. It was totally impossible to do a suture by endoluminal way. So you imagine that today, if you have the detection of an early cancer for alimentary tract surgery. That will be an ambulatory way for the treatment. And that is for the next 10 or perhaps 20 years. It will be long, but sure, due to the early detection, it will be the future. And now another one, a company which is fantastic, that always, Chinese, because every year they have 5 new robots in China. And you see that they have also this kind of new robot. But something is fantastic is that you will see a triangulation of more than 11 centimeters. So that means they have no limit for gastric cancer. If you want to do, for example, a full thickness of the gastric wall, it will be possible. And that will be certainly on the market in the next 2 years. One word very important for oncology surgery, it is remote telesurgery. We had a consensus conference in Orlando in the United States 2 months ago about that. It's funny to say that we had in 1994, so imagine 30 years ago, we had a grant from Europe to develop remote surgery. And it was the first time that we have performed a remote surgery. It was a cholecystectomy between New York and Strasbourg. I was in New York, my patient was in Strasbourg, and it was the first time that we have done this kind of operation, which has been published in Nature in 2001. That was a Lindbergh operation. So it was not a surgical challenge because it was an easy procedure, but it was a challenge of information age, how it is possible to do a precise surgery with more than 14,000 kilometers. So that was the setting of the robot. At this period, it was the robot. So imagine that was more than 22 years ago. And you will see a lot of engineers, more than 80 engineers of France Telecom, because at this period, the problem was a delay. So that was the platform in Paris. And I was personally in the subsidiary of France Telecom in New York. The name was Equant, and the operation was performed and published in Nature. But what happened now? Now, 20 years ago, it started just in 2020. First trials in China with 3,000 kilometers. It was a preclinical data. And after that, explosion in 2023. In 2023, 100 cases performed with remote surgery because in China, they say that is the only way for what they call healthcare equity. Because China, they have fantastic hospitals in Beijing, in Shanghai, in Hong Kong, but in all the area, they have nothing. So the only way to develop minimal invasive surgery will be remote surgery. So the same for Japan. You see, Japan, they have done a lot with the Kawasaki robot Medicaroid, a lot of internal, that means in Japan, remote surgery, but also from Japan to Singapore. And look that, it was a kidney cancer. And the kidney cancer, it was a triple consult surgery in China. That means 3 surgeons in Beijing operated in 3 different hospitals in China. And that is really a revolution. And we want absolutely to do the same. I know that we are going to discuss in 1 hour with the Minister of Health of Rwanda, because we have a program to do the same on the African continent, because I think that is also the future to democratize minimal invasive surgery for cancer. A word about real life. What I show you just before, we all dream. It's fantastic. It is what I call the Ferrari or the Rolls-Royce. But that is not the real life. And during the COVID, I had the possibility to discuss with one of the directors of the WHO. And I discovered something certainly you know, but that I didn't know, that 5 billions of the worldwide population don't have access to a medical imaging. That means a simple X-ray of the lung. And in the Lancet, we know that 5 billion of the worldwide population don't have access to surgery. So that is something, and we change totally. So that means when we discover that, we say we continue to work with the Ferrari, but we need to imagine something else, a low-cost approach for diagnosis and for treatment. So the challenge was very simple. We know that if we detect a tumor, of less than 1 or 2 centimeters for the kidney, for the lung, for the liver. We don't need to operate the patient. We can do an ablation by radiofrequency or cryoablation. So what we did, first of all, it was the beginning of very low probe, ultrasonography probe, $500. But with artificial intelligence, with this probe, can be with a cable or Wi-Fi, we can have an automatic detection of little tumors of less than 2 centimeters. And that was done in 13 months due to artificial intelligence. Normally, a work like that will be more than 5 years. And after that, we said we need absolutely to transform this 2D image of the low-cost probe in a 3D image. That was done. And after that, we need also to think about a low-cost robot to do the radiofrequency or the cryoablation of the tumor. And that is a program we have done. So look, that is on the mannequin, but all the data are from human, the automatic detection of the mass. After that, we want to have a 3D image. So it's a really low-cost robot, but we need a robot because we need to have the same pressure. And you see, we have an acquisition of more than 150 images per second. And because we have this kind of possibility, immediately in real time, with a low-cost probe, we have the 3D image and the visualization of all the vessels. So it's so easy for a surgeon or with a support of a robot to do that. I just want to do some word about the training because it's time. We cannot imagine this kind of development of new technology without a training. And that is also one of the reasons has been created by really the push of President Paul Kagame IRCAD in Africa, in Kigali. That is my generation. I was trained like that in New York. You imagine that was more than 40 years ago when I was resident. And you see, impossible to learn something. Today, everything changed. We are connected every day, every morning with 3 auditoriums with the best operating room in the world. We want to teach how to operate a gastric cancer. The only possibility is not to be connected in the United States or in Europe. No, they have not enough case. We are connected with South Korea because each department has more than 1,500 cases per year. Today, if we want to teach how to operate cancer of the liver by minimal invasive surgery, we are connected with China because the anti-cancer of Shanghai, they have 4,000 cases per year of minimal invasive approach of cancer. After that, you see the training, they go up, like in IRCAD where you are, in IRCAD Africa, they go up in the lab because they need, it is a companionship surgery, the same for endoscopy course and for the robot. And today we start by 1 robot. We have 32 robots, intuitive surgical robots, but a lot also of Medtronic robot, Cambridge Medical robot with a lot of new platform. And for the surgeon, especially for oncology surgery, we have developed, and that is free of charge, WebSurge, which is a virtual university on internet that is translated in 7 different languages. It is free of charge. And you see, we have 500,000 of active members. So it's totally interactive. They can really learn a lot about especially the strategy, but also the technique. And I finish now by the globalization. Impossible to do research and training in only 1 center. And you see that today, IRCAD is totally around the world, except today in Russia. But you see, we have 1 is going to be finished in United States, in Charlotte, in North Carolina, 2 in Brazil, Sao Paulo, Rio de Janeiro, 1 in Beirut in Lebanon, 1 in India, 1 in Taiwan, 1 in China. And you have seen 6 months ago the opening ceremony of IRCAD Africa, which is exactly the same standard than IRCAD France. So thank you very much for your attention. It was a pleasure to share that with you today.
Thank you very much, Prof. Jacques Maresco. That was wow, AI. But I really like the real life part of it because that's where we have a gap, and that's why we're here today. So it's my privilege to welcome our next speaker, who is the keynote speaker. And this person happens to be my lecturer, so that's why I'm privileged to welcome him. Dr. Jerry Ndumbalu. He's a clinical and radiation oncologist from Tanzania, and he's also a founder and president of the Tanzania Oncology Society. Shikamo. Karibu sana.
So in Tanzania, we greet an elder by saying shikamo. So to all elders here, shikamo. And to the younger ones, we say marahaba, meaning that you are greeting an elder. That's why she said shikamo. So we were with her for almost 3-4 years in Tanzania, and she learned Swahili. So if you want to learn anything in Swahili, you have to be close to her. So yes, wow, it was wow from Professor in Irkada, France. But let me take you back to the reality, what we are and what we were and what we have to go in Africa. Can I have the presentation? So as introduced, I'm Dr. Jerry Ndumbalo. I'm a clinical and radiation oncologist. I'm also, as she introduced me, a senior lecturer at our Muhimbili University of Health and Allied Science in Tanzania, and also a founder and a first president of Tanzania Oncology Society. I have a very short presentation just to state or to see what are the gaps and where we should go. So please, can I? So I don't have any conflict of interest apart from the travel by International. Yeah, and I happen to be a commissioner of Lancet Oncology in Africa. And before you act, you have to research. Before you do anything, you have to research. So in sub-Saharan Africa, as well as in Africa, in terms of oncology and cancer, we had to research to see what is the baseline, what is the situation currently. And this happened during the period of COVID era. And during this period, it was very, very difficult for any patients to travel even outside the region, not only the country, but the region. And that is the time when we saw that our health system is not intact. And during that period of time, we had to research what is there in Africa. So the whole Africa participated in this research, Lancet Oncology. And during this time, then we highlighted what our priority areas and how to go through them. So we had 8 just bear with me 1 minute. So we had 8 action points that after doing the research and finding out what is the problem in sub-Saharan Africa and African as well, and we published those, the key areas or the key problems or gaps that we have in Africa, in sub-Saharan Africa. And we also call upon from the level of governments to all the stakeholders, partners, until to the level of clinicians to act on these 8 action plan. Those are the ones that I want to show you, and we can have a discussion from there. Please. I can use my computer quickly. Can I bring my computer quickly? Yes. So where can I connect here?
I think, yeah, let me ask this guy is coming.
Because I brought it to them. I gave it to them. Can I not connect directly?
Okay, let me just tell the guy to.
Because I gave them the.
Okay. Okay.
Oh yes, please. You're there. Right. Sorry for that. Technicalities. So, as I said, we published this article in 2022-2023 with the Lancet, and it's basically we involved the whole of Africa, and we had representatives also from here, Rwanda. We had a Fidel and Christian, Dr. Fidel and Christian as well from here. But it was represented from all over Africa to know exactly what is the situation currently in terms of the cancer care, especially after we have been crippled with the COVID era. So the estimation has already been given, Dr. Islam, and as well as they stated regarding the burden of cancer. It is very rapidly growing. The estimates showing that we are going to have almost 1 million patients in sub-Saharan Africa by 2030. And as I said, COVID burden made this situation worse. So we had to intervene to know exactly where we stand so that we can plan for our future. So this is very important that most of these plans, anything that you are doing, you have to have a political will, a political support. So what we did is to launch this report. We wanted the President of Tanzania, Honorable Samia Suluhu Hassan, to launch this report. And basically, she agreed to launch this report. And just a day before the launching, she had another commitment, so she couldn't make it. But the whole delegates from the level of Prime Minister's office, a Minister for Health herself on yellow jacket, and also we had a minister from the Zanzibar Revolutionary Minister for Health on Zanzibar on the red tie. So all the delegates basically and all the leaders in health in Tanzania and East Africa, we had a representative also from Rwanda, the ambassador from Rwanda and all other African countries that were there. So this is very important that because most of these plans, they involve directly the government as well as the ministry, our ministry of health. So this was our very first target. We involved, we had a political will. So basically, this report, as I already pointed it out, we had gaps that we saw in the whole Africa, and basically it was uniform from all these regions, all these countries. We had almost same problems. So the very first one was registry. So most of our countries, we don't have cancer registry. You cannot plan if you don't have information. You cannot plan if you don't know the burden in the country. Most of these data that you are seeing, 19,000, whatever in sub-Saharan Africa, most of them, they are estimates. We don't have actual data from our setting. Most of these, we see GlobalCan, they are projecting them. So we don't have these actual from our country. So the very first thing was we don't have cancer registry. The other ones was cancer control plans. Most of the countries, there are several countries that they didn't have even a cancer control plan. You know, most of the countries, they were putting cancer in this NCD bucket. Everything is put there. We have a national NCD strategies and all that. But some countries, they didn't have specific strategies for cancer. And this is bad because when you have diabetes and you have hypertension in one basket, then definitely your cancer will be pushed aside. So we have to have the cancer. And also, we talked about universal health coverage, screening and detection, palliative care, oncology workforce, research, and also telemedicine, as I said, because of COVID era. So I put this statement here. This was stated by our Ministry for Health from President herself. She said, we are taking seriously the report recommendation, including updating the national control plans and investing in developing cancer as well as the cancer registry. So this was a statement from our minister, who was the guest of honor in this launch. So call for urgent actions. These were actions. We had 8 actions that we wanted each country, every part of Africa, to work on them. And also we gave timelines as well, if you are to reach a goal. So the first one was cancer control plan, as I said. We have to have cancer control plans. This will take us for 5 years, 10 years, even 25. Some of the countries, they even have a 25-year plan on the health as well as NCD and cancer inside it. So this will help in accelerating our control. And there was a group of African presidents, ladies. They have their group that they are promoting screening as well as cancer control. And this also helps us easily to navigate in most of these governments because they are there, hands-on. They know exactly what is going on in terms of cancer care and prevention. So we had a time frame of 5 years that every country, at least, they have to have a direction when it comes to cancer control. The second one was data, as I already pointed it out, that we don't have information, actual information. Most of the time, we just rely on data that are from outside our environment, and most of them, they are just projection. So we don't have actual cancer registry from our hospital, from a community-based registry, so that we can have exact data. So we have given 3 years, maximum, for most of our countries at least, to establish these registries if they are not there, and if they are there, at least to strengthen them to have actual data. So we have people from the RBC here. We have to take this thing and put it into action here in Rwanda. In Tanzania, We have established, we have hospital-based cancer registries in most of the centers that are treating cancer. We have 6 centers that are treating cancer, national centers, that they have their own registry. And we have started a population-based cancer registries in some parts. So we have one in Dar es Salaam, one in Mwanza, one in Mbeya, and one in Kilimanjaro. So with these population-based, at the end we'll have a national, because of the funding and all the resources and all that, you cannot start it at once. So we started it in patches. So we are expecting it maybe in 3 years, 5 years time, we'll cover the whole country. So data is very, very, very important as action number 2 in order for us to fight this problem. So we have the systems. So most of countries that we researched, health financing is an issue. Cancer, especially cancer financing, is an issue. We had, when we were in medical, in oncology school, we had this 4th term that we call it financial toxicity. You can have toxicity from the drugs, but there is also another toxicity financially that most of these people are sometimes even selling their lands, selling their houses in order for them to finance or to fund their health. So it is proposed that we have to have a universal health coverage in terms of the insurance in our countries. Some countries like Rwanda, I think they've got a bit a step ahead, but there are some countries they don't even have health insurance for even quarter or 1/10 of their population. So this is also argued for our governments and for all the institutions that they have mandate in terms of health financing, find ways, including health insurance that is universal for our people, So also in terms of cure now and cancer care in general. Prof was talking here about AI, and we were even, doctor said, wow, because it's a thing that we are we're inspiring to do it probably in the next years. But I can give you a short history about oncology in Africa, especially in East Africa. The past 5 years, only 5 years, we were not able to do any radiotherapy to the breast, proper one, head and neck, any brain tumors, because we didn't have any sophisticated machine. We just had a plain cobalt machine. These are the ones that you are limited, that you cannot do any of those sites that I have mentioned. But as currently I'm speaking, in Tanzania we're almost going to have like 5 new linear accelerators. 2 that are newly installed, will be newly installed at Aga Khan. Temel is here, please stand, they'll see you.
Thank you very much, everybody. Thank you very much, Dr. Jerry, and the chance to share the work. I'm regional manager for Electra, and I'm medical physicist by profession. So I worked in radiotherapy sciences in my country, Turkey, for 10 years. Then I moved to Kenya, Nairobi, in Kenya, to become closer to our patients and our clinicians and hospitals. So,
microphone, and then we can hear you better and put the microphone up. Oh, perfect.
Thank you.
Thank you so much.
Thank you, sorry. So actually, as Dr. Jerry mentioned, we are now about to complete 2 linear accelerator installation at Aga Khan Hospital in Tanzania, which are the state-of-art technology, and it will be soon, just coming weeks, we'll be ready for the patient treatments. And it's also a part of PPP project in Tanzania. And we are very proud to bring this technology for the public services especially. And we are very much looking forward to extend the same proof of concept for the rest of the African countries. And thank you again, sir.
Yes, so PPP also works. So in Tanzania, we had this PPP. We had a program that called Tanzania Comprehensive Cancer Project that is partnering between private and public. All in all, it's just to have these machines that we don't need to send anyone outside the country for a very simple treatment that doctors are here already to do that. You just need the machine to come here. So this was also action plan that our countries, they have to invest in these treatments and diagnosis of the cancers because the main thing here is mobilization of resources. And resources are there. It's just the priorities. Most of our countries, the resource, if you are looking for it, basically, it's there. Just priority. So in terms of improving cancer treatment and care, we urge our government, we urge private parties, we urge everyone, especially in terms of PPP, to make these treatments available. So ARCAD and France as well, we are probably in some years, you can even open a center here with all those robotics, and people in this region can access. So we had in the same PPP, we are partnering with one organization in USA that are bringing proton therapy in Tanzania, which is not available in all this region, except maybe in South Africa. So those are the kind of PPP projects that they will help our patient at the end. So it's not only the government, but also private and every stakeholders, they have to play their role. That was number 4 in terms of treatment and cure. So most of our patients, as you know, they come at a very advanced stage. Most of them, they are stage 3 and 4s. So we have to also invest in palliation. So in this study, when we were doing a background check, there are some countries that don't even have a morphine. And their policy of getting morphine, it was very, very difficult in some of the countries, which is just a simple drug that you can administer to patients and palliate them, because majority, as I said, majority of our patients are coming at an advanced stages. So optimal palliation, optimal pain management was one of our action plan that most of our countries, they have to invest on. And this one is not expensive. So in a year or 2 or 3, at least we have to have a national plan in our countries for us to establish this palliative and support program, as well as a rehabilitation program for our patients. Number 6 was workforce. I was just talking to Daktari here that we have, he was stating that Tanzania, we went ahead in terms of this action plan in building the workforce. We have training programs in Tanzania for oncology, nursing oncology. Now we are almost going to start a medical physics program. We have radiotherapy programs. And the only few African countries had these programs. So what we are commending, or what we want, we are recommending that we have to have these programs in our countries, because it will be customized based on your patients, type of patient that you are seeing, and your environment. I can give you a history. We had one physicist who was trained in Italy, and he was trained with, as you can see, the robotics and all those IMRT techniques. And when he came back to Tanzania, it was difficult even to do the basic simple stuff. He knows a lot. So we have to have these trainings locally. Yes, we usually partner with the outside to get the advanced technology, to get an advanced knowledge and all that, but at least if the training will be here, you will customize it based on the local environment. So we said most of our countries, they have to build their own workforce inside their country to be easier. And if you cannot, then you do the regional collaboration with the nearby countries like what we do in Tanzania and Rwanda to have these oncology programs and trainings. The 7 was research. We pulled out all the African literatures and published research in this project. And we mapped them, where they're coming from. So you can see 80%, probably 70% was coming from South and North. If I can say South and North, you know. So it was South Africa and Egypt, Algeria, Morocco on the north. So here in sub-Saharan countries, it was almost like 30 of the publications that we pulled just writing from Africa. You understand? So we argue that we have to have the information about our own patients. Because even these drugs that we are using, all these medication that we are using, even the toxicity, side effects, we have different genetic profiles. So the toxicity that the Chinese can get with this drug will definitely be different from our setting. So we have to have studies, we have to have research collaborations within the countries. Yes, we need partner from outside, but at least if we can study our own population, coming up with our own answers so that we can at least improve our cancer care and service. The last one was telehealth. As I said, during the COVID era, and even this project, we did it in COVID era. Everyone on their home. We had a lot of Zooms and teleconferences, and within that, we managed to come up with all these reports. So it's possible to use telehealth to improve our care. So as what Professor was saying, he was in New York and he can do something in another countries. We can also impose or improve in telehealth. In Tanzania, we've started in pathology, and also we are going to radiology as well. Pathology meaning that the sample is in another region, they just take a biopsy or whatever, even if it's FNA, or that they stain it, they scan it, and the pathologist is on the zonal hospital, maybe 300 kilometers away. So they just scan the slide, they send it electronically, they read the report, and they send their email back. So because of this workforce that we are talking about, we also have to make sure that we invest a lot in telehealth. This one, as you can see, during COVID era, as I said, we couldn't even fly anyone out. So it helps us a lot during consultations with doctors from outside. We did a lot of tumor boards with the people from different countries and help us improving the care as well as our outpatients' outcome. So those are the 8 action plans that I wanted to share with you. And please, everyone on their part, every stakeholders, I think you have 1 or 2 action plans, 1 or 2 things that you can do from these 8 action plans. And if everyone does their part, I think in 3, 4, 5 years, we'll be at the next stage or phase in cancer care. Thank you.
Thank you very much, Dr. Jerry. Allow me to welcome our next speaker, Dr. Sinead Kabede. She's a global health doctor from Emory University, USA. You're welcome, Dr. Sinead.
Good morning. It's a pleasure to be here. It's a pleasure to be here, and I apologize I came late. So if I repeat some of the things that previous speakers have already said, you will bear with me, or you can stop me. We've heard it, and then I can sit back. Regarding the background of myself, I am a pediatrician and a global health professional. Most of my work has been on maternal and child health, guideline development, strategy development, planning, and policy development. Right now I'm teaching at Emory University in Atlanta, Georgia. So most of my comments might be a global kind of perspective, but I've been practicing pediatrics for the last several years before I joined the global health arena, and I usually am affiliated with one of the schools in Ethiopia. That's where I am from, so I get to practice here and there. So the background of cancer, we know that the burden is swiftly escalating. Okay, can you hear me now? Okay. We know that the burden of cancer is escalating everywhere, but there is an alarming increase when we talk about cancer in low and middle income countries, particularly the African situation. 19 of the 20 countries that have high incidence were in Africa when we compared the LMIC rates. And I'm sure you've gone through this. The projection is also painting a grim picture. So by 2040, we know that we will have more than 2 million cancer cases. Despite that 80% of cancer is in low and middle income countries, only 5% of resources are available for cancer control in the region. So again, that is also another important challenge that we are grappling with. So increasing life expectancy, urbanization, population growth, and lifestyle changes may have contributed to this effect. Not to forget also the relationship between alcohol and cancer. I'm sure you have gone through some of the presentation, I'm not sure, or it will be coming. Alcohol has been known as a carcinogenic, and in breast cancer and others, there are several studies that we can refer to. When we look at the scientific developments, there are so many developments in the last decades. Innovative technologies, which have enabled us to understand cancer more deeply, have been very instrumental in improving cancer care, cancer diagnosis, cancer prevention. We talked about AI, and I'm sure we've covered that. Wearable technologies, and also in-depth understanding of the biology of cancer itself in treating intractable conditions like glioblastoma and pancreatic cancer has also made the headway in the scientific developments. Another one is modulating the human microbiome, which is the next frontier in cancer. So there have been a lot of scientific progress that has been made over the last decade that is helping improve the quality of life and improve survival of patients with cancer. But these technologies or these benefits are mainly concentrated in areas where you have the infrastructure, the workforce development, where you have institutions, and where you have the supplies that are available to make sure that you can use these developments to advance cancer care in your locality, and that is usually in the high-income countries. So despite all these developments, we are not benefiting as much as the other countries which are having the resources to move forward with improving cancer care. I don't want to go into the limitations. In general, we have a weak health system. But on a positive note, there is a great progress in the African region, one of which is, in fact, in this country, the human papilloma vaccination is more than 80%. There are a number of initiatives in multiple countries that we heard from our previous speaker. There is a progress that is moving forward that gives us hope that we will have improved cancer care for our population. However, these efforts need to be amplified, and we have to recognize the urgency of action and also our advocacy for our patients, and on also improving, influencing policy, and not only having plans and policies in place, but making sure that they are implemented, documented, and we are really monitoring our progress becomes critical. I just want to share with you one story when I was practicing pediatrics back home in Ethiopia. I think we all agree that cancer has a profound emotional weight, not only on the patient itself, but the families. When you have cancer, you have to think about what will happen to, if you are an adult with children, you have to think about this terminal illness and what you need to do to care for your loved ones. When it is a child, it's more serious. I find it very emotional when we see cancer in children. I had a patient who was 5 years old with cancer, and we were treating him with whatever was available, and this is a long time ago, and I don't think there is much has happened in terms of improving cancer care for children in Ethiopia, and for that matter, in many African countries. The chemotherapy regimens, they were not complete. If the child requires 2 or 3, we have only 1. Radiotherapy was not available. Palliative care was not available. And this was one of the patients I was very much, I don't know, somehow attached to. This was a 5-year-old, a sweet kid who comes once in a while to get treatment, having repeated relapses. And this child died. And I find that emotionally very heavy on my side. And I felt in saving this child just because he lives, or this family lives in a country where we cannot afford to have adequate regimen, cancer regimen, to benefit our patients. And I think the pediatrics part, or the childhood cancer part, is in fact the one which is left behind. I don't think it's any better in the adult, but if we compare it, I think the children are left behind as well. So when we think of improving cancer care, we have to remember that we need to ensure that childhood cancer is also taken into consideration. Maybe it's because I'm a pediatrician, I'm voicing the childhood cancer here, but I'm sure all of you agree with me the psychological toll it takes in our communities when a child has cancer. So what needs to be done is, as already mentioned, we need to act urgently. I think we've been slow for a long time. I think it's time to kind of pick up the pace. I did say that there are improvements and which are encouraging, and there are positive practices that are encouraging. There are so many steps being taken, and Rwanda is showing, the way ahead as well. But I think we need to pick up the pace in terms of cancer care. First and foremost is the plan. Many countries may not have a plan, but those who have a plan, they have to make sure that it is interpreted, implemented accordingly, and it's followed, monitored, and also there is a continuous improvement in the cycle of planning. We have to attend to the comorbidities like HIV, malnutrition, as well as the palliative care component, which is really very much also lacking in terms of attention in the health care field. Successful models are already existing. The psychological therapy or the psychotherapy that is required for parents, for families of cancer patients and the patients themselves is also critical. Leveraging technology is also another main area or important area. This kind of meeting brings the idea of coming together, sharing experiences, learning from each other, and then creating opportunities for collaboration a reality. And I think that is what we need to also kind of embark on and also make use of these connections to boost our work in the research area, in the implementation area, and also in the data sharing and information that is relevant for improving policy or influencing policy, because we are interconnected from the region. And I am very hopeful that these 2 days will give us some way forward for us to kind of identify areas of collaboration that will be coordinated and also improve our partnership moving forward. In conclusion, the efforts to prevent and control cancer and bridging the gap in patient care, research, and education could be addressed. They are not insurmountable. We can do it, but we need to have collaborative effort and advocate for our patients. Thank you.
Thank you so much. Let's give a round of applause to Dr. Senate Kabede for that presentation. Thank you so much. We want to go to the section of sponsors, but before we go there, we'll play a short video. I'll ask the media team to play the video for our first sponsor, which is WaterAid. They will be playing it shortly. Will be just after the closure of the sponsors presentation. We'll then go for a tea break. I know just a short time because we, according to the program, but we will be working with 5 minutes for those who are going to come and do the presentation, so that we are in time for the tea break. So, media, I give you the chance to play the video for the sponsors. WaterAid. And whilst they are coming, I will call upon Mr. Maurice Quizera, to also, who is the regional country director, to walk to the stage whilst the video will be playing shortly. Thank you. Let's give a round of applause to Mr. Maurice Quizera. Thank you.
Yes, good morning once again. As we wait for the video to come, I think some of you must be tired because you have been in the room for 2 hours already. But the good thing is that I'm not going to repeat any of the things presented by my predecessors on cancer care, simply because I can't. my area of specialty is in water hygiene and sanitation. Does it have a voice? No sound?
Cancer itself, it's a disease that weaken immunity of a patient who is suffering from that. Cancer itself, it's a disease that weaken immunity of a patient who is suffering from that cancer. If one has the weakened immunity, it means he or she is prone to infection. A patient may die not because of cancer, but because of communicable diseases, which are preventable through improved wash performance.
Thank you very much. I think the starting part of it had no sound, but it's okay, you were able to read the message. Dear participants, it's truly an honor to me to stand before you today representing WaterAid as one of the privileged sponsors to the first E3 International Cancer Conference here in Kigali. And indeed, it's really, I feel a privilege really to be able to sponsor this conference, and it humbles myself to be able to contribute to this wonderful, great conference. Cancer stands as a challenging adversary that affects millions of lives globally. And according to the International Agency for Research on Cancer, there is a growing burden of cancer with a disproportionate impact on underserved populations. And therefore, we all feel an urgent need to address cancer inequalities worldwide. WaterAid's mission is to transform the lives of the people by improving access to safe water, sanitation, and hygiene, the components that are all fundamental to achieving good public health. For the case of cancer, we strongly believe that universal and permanent access to clean water, sanitation, and hygiene are all essential to prevent and manage diseases such as cancer, infection prevention and control, as well as other pandemics. I saw one of the objectives of this conference is to explore strategies for delivering cancer care in regions with limited resources, focusing on innovative and cost-effective approaches, which I believe speaks to the mission of WaterAid. It's clear that clean water and good hygiene practices can not only prevent infectious diseases, but also contribute to the reduction in the development of several types of cancer. The association between water hygiene and cancer should be emphasized in various cancer prevention programs. Let me talk a bit here about the quality of water we use. some water contaminants like arsenic constitute serious risk to the cancer of the liver, lung, bladder, and even kidney. And in our area of work, if some people are willing to invest in clean water, it's very, very few people who are concerned with the water quality. One of the requirements for cancer patients is healthy eating, including adequate consumption of fluids. But this cannot happen without availability of clean water and proper hygiene. The same applies to other tips to keep healthy life, like skin and mouth care, bathing, and others. You will also agree with me that clean water in healthcare facilities is very key to infection prevention and control. According to recent data from World Health Organization and UNICEF, there is 700 million people in the world who don't have clean water close to their homes. There is also 1.5 billion people who don't have a decent toilet to use. And globally, 3 in 10 schools, for example, don't have access to basic water. These statistics have faces, and we should not ignore them, especially when we think about cancer patients who might be included in those numbers without access to these basic necessities. WaterAid has reached millions of people in some of most remote areas in the world, but we must work with greater urgency because our target is to reach everyone, everywhere with those services. We are in 22 countries globally, but here in Rwanda, where we are today, WaterAid has provided water to almost 1 million of people. And more than 245,000 got access to sanitation, while 2 million people were reached with hygiene behavior messages. We believe that access to water, sanitation, and hygiene for all can be achieved, but it will happen only if all stakeholders in development and public health become aware of the impact that WASH has on health and other development areas. At this conference, WaterAid will be an unusual participant, discussing only about water hygiene and sanitation. I need to close by calling global leaders and future leaders and current leaders here in the room and decision makers to emphasize more and more on investing in water and sanitation and hygiene, so that together we can create a world where everyone, everywhere has a healthy and dignified life. Thank you so much for your kind attention, and I continue to wish you great, fruitful deliberations.
Once again, let's give a round of applause to WaterAid. Thank you so much. Water is life. Thank you. I think I liked his presentation more because my name is Walter. We removed just an L. So I thank you. Whenever I speak about water, I think I need to have some shares at WaterAid. We call it WaterAid. I don't know. So thank you so much. Then, ladies and gentlemen, I want to acknowledge the Executive Director of Partners in Health, Ms. Nadine Karema, who is absent and going to be represented by Dr. Frederick Katera, who is the Deputy Executive Director of Partners in Health. Please, ladies and gentlemen, let's welcome Dr. Frederick Katera to the stage to give us a presentation.
Good morning. It's just a little cold. I don't know whether we need someone to wake us up a little bit. I can imagine both hungry and cold at the same time, not a good combination. It's a privilege to come to this conversation. Among other reasons, I believe we have made a lot of progress, and because of that goodwill, I think there's a lot of interest to see how we can grow cancer care in the countries that we work in. And looking around the room, I see lots of people who are really great partners, I think, to push us forward. So it's a good day overall. And I think today, compared to 20 years ago, when you looked at cancer or you had something like cancer, it was almost a pronunciation of death. So in many ways, we have been speaking to death, and we've made a lot of progress. I think we should give ourselves a round of applause in contributing to that. So Partners in Health is an NGO. We are not a profit company, hence there's no advert or anything like that. Our job really is to invest in healthcare, to improve outcomes of people who are vulnerable. Our investment is primarily through government establishments. We do not run a private entity. We are not a for-profit company. Ours is try and strengthen the government healthcare system. So as an NGO, we are really in every country invited by government, and we work within government institutions. We believe it's the most sustainable way of strengthening the healthcare system, not just vertical programs like cancer, but the healthcare system overall. And I think as we grow in understanding the challenge of cancer, I think we all appreciate that you need a healthcare system more than you need vertical interventions. So in the last 20 years, we've worked in Rwanda, and specifically in the last 12 years, our focus in cancer has been focused mainly in one hospital in the country, in Butaro Hospital. Now it's a level 2 teaching hospital. Our heartbeat really was to try and demonstrate in principle that we can have a cancer center with integrity, with quality of care in a rural setting, closer to people who most need that service. And I think we have been able to demonstrate that in principle. The center is located about 2 hours drive from here. It's set up in a government hospital at the level of a district hospital, a bit now uplifted. And we worked primarily to establish, number one, diagnostic services, because without diagnosis, you have no entry to care. The first point of investment is actually a quality diagnostic service. So we run probably the biggest histopathology lab in the country that supports other care centers as well in the country. Our next investment really was in establishing the infrastructure, building a hospital that was really centered on cancer care. It still serves other non-cancer needs, but the bulk of the investment, the bulk of the HR, the bulk of the trainings has been really centered on having a cancer center so that we can demonstrate that rather than private clinics where someone goes to a private physician, we can actually have a systematized approach to cancer care. And you have protocols that can be scalable at country level. You have innovations that can be reproduced in other centers. So that's been sort of our approach. It's mainly been a health system strengthening approach rather than a vertical approach. So we primarily offer chemotherapy. That has been the heartbeat of our investment. And as you can imagine, there's so many cancers. Our first approach was to look at the most prevalent cancers. So we focused on the first prevalent cancers. And over the last 12 years, we've been increasing the range of cancers that we can treat. But one of the realities you hit with cancer is that every cancer is like a disease on its own, separate from the other cancer, in terms of the histopathology, in terms of its cure rate, in terms of the treatment modalities involved. So every time you add another extra cancer, you're almost managing a completely different disease. And so it's a bit of a complicated system. And that's a reality, I think, as we sit here, we need to have a conversation on. It's not like setting up, let's say, an MCH department that can handle 12 diseases in one center. Every cancer is different. And so the resources needed, the capacity needed, the systems that need to be there, the treatment modalities have to be almost centered around that particular cancer. So that's one complication. The second complication is that, especially when you look at chronic diseases as different from primary healthcare diseases, we need to find systems that are patient-centered. We are far from where the West is right now, but when you talk to a cancer patient, in as much as they have a disease, they have so many other complementary challenges that need to be addressed in order for them to actually get the cancer they need. So we've been working over the last 12 years to transform cancer from a health facility-based approach towards a patient-centered approach. And we can demonstrate that, I think, in the growth that we have made. And we've seen that, for example, investing in finding equitable structures like patient navigation. We assume that when you send a patient to a hospital, they will find their way, they will be equally received, they will be housed, they will be fed. But we all know that's not true. And it's not enough to give someone chemotherapy. They need to eat food, they need to be housed somewhere, they need to get the other complementary radiation they need. And so for many of us, I think we need to look at it more from that approach if we're going to have the impact that is needed for that patient. We also need to be aware that we're working in resource-limited settings. And apart from the systems being suboptimal, the patients themselves can hardly afford most of these medications or even the diagnostics. So if we don't think systematically and we don't think innovatively around the other complementary support they need, especially financing solutions, we'll be able to have a service, but no one will access it. And so we've not done anything. So apart from bringing in drugs, and we've been catalyzing bringing in chemotherapy into the country at a time when we didn't have any other center offering that, but that has improved, and a lot of shout out to the government for a lot of progress in that. But apart from bringing in chemotherapy, we've been also able to think through how to finance or to provide finances for patients who come. So because we're an equity-driven initiative, we believe that healthcare is a human right. No one should be denied care. It's a lofty ambition, I agree. But if you come to our facilities, you will get care one way or another, whether you can afford it or not. So the challenge then is who pays the bill, but that's a separate conversation from the patient who came into the door. They should be able to get the care, if the care is available in the hospital. We believe that where you're born or your circumstances should not determine whether you live or die. So we do our best to make sure that there's equitable care, it's quality care, and that just because you do have or don't have resources, you should not be treated any less than the other person. So among other things, we were able to think through pragmatically. If you introduce a cancer center in a rural area, you will not get an oncologist coming. You will not get an oncology nurse coming. You may not be able to get a radiation expert coming. So we were able to catalyze and demonstrate from the very beginning task-shifting initiatives that could get capacity to people who are not specialists, but without undermining the quality of care. So we've been thinking through different mentorship models that involves us to bring in senior oncology nurses from the US who are embedded into the program for years to be able to really provide quality experience and learnings, but with hands-on approach rather than educational programs. Not to mean that an education program is not effective, but for most of these complicated diseases, you almost need someone to handhold you and to pass on skills and competence and experiences. It's not as easy as most of the other, let's say, non-medical challenges that we have. So cancer care is a lot more complicated. It requires a lot more experience. It requires a lot of mentorship. It requires a lot of complicated protocols and a lot of mentorship around navigating those protocols. So our model has been really task shifting, has been really supporting mainly pediatricians and some of our obstetricians to actually act like oncologists and have those competences. And we've been able to demonstrate that. The good place we are in now, we have better capacity to hire oncologists. That doesn't undermine the previous cadres. We actually are able to work even better with a combination of both. Because then again, you may never get all the oncologists you need in a center as you work. Even within the cities, you may not be able to get that. I think what has really helped over the years has been also the availability of radiation. We used to literally fly out patients to get radiation to Uganda and then to Kenya. But now with Rwanda Military Hospital at the Rwanda Cancer Center, we are able to have access to radiation, and that has really improved not just quality of care or the speed of care, but just the convenience of the patient and the ability to be treated in a setting that is socially agreeable to them and they can be supported even as they get care. Before that, if you fly someone out of the country, we often think they went for care, but we don't understand that human beings are complex. You need a support structure around you even as you're getting care, and we've been able to do that. Now, we are now leveraging on 12 years of experience and really showcasing from implementation science some of the lessons we are learning, some of the research that has been published, to try and see how much of those learnings can be curated towards improving care and expanding it outside just our hospital. So working with RBC now, we are improving on diagnostics, because again, previously, every patient would come to the center to have a biopsy taken, to have a tissue processed, and that was not going to be very feasible long term as more and more patients come in. So we are working at 5 centers now to improve diagnostics, hoping that these centers, because they'll be closer to patients, there will be increase in access. We are also working at really, for patients who need chemotherapy, oral chemotherapy, who don't need to be hospitalized, there's no point driving to Butaro. So we are looking to capacitate, again, 5 hospitals across the country to be able to provide oral chemotherapy and be able to follow up patients closer to their homes. If we do not make care patient-centered, we are going to be asking too much from people who are sick, and many of them are debilitated. And I think a colleague talked about financial toxicity. It really is not helpful to treat someone for cancer and leave them financially disabled. You've dug one hole to fill another, and so we need to do better. So cancer care for me is a holistic approach. Apart from just the AI information we are getting and all the advances in science, we need to think about the human being and the toll that they go through when they're getting cancer and the entire network structure that is needed to protect them as they get cancer. So I'll probably mention two paths that we are looking at in terms of growth. One is most of the medications that we have been using are relatively outdated. Cancer care is rapidly evolving, and apart from cost implications, access challenges are also becoming a challenge. But we are really challenged now working with government to improve on providing newer molecules that are less toxic and more impactful. That's a challenge that we are handling right now. The next challenge for me really is looking at integrated pathways of care. We cannot manage every patient in one hospital, even in the most advanced hospital. So we need to leverage the existing competences and see how we can partner with other people to provide cost-effective interventions for the whole country. 3 is, even with all these investments, the majority of the patients are still coming in late in their course of disease. So figuring out public health interventions or access initiatives that can identify people early on in their cancer journey will allow us to be able to treat patients better, get better outcomes, probably less toxic outcomes, but also be able to provide care for cheaper. It's a bit sad when you have the medications, you have the diagnostics, but the patient comes in stage 3, in stage 4. I mean, it's sad that the medication exists, but now the patient is far advanced and they cannot respond to the treatment. So if we can try to identify patients early on in their journey, I think that would be a lot of progress. But to do that, we need services that are much more patient-friendly. We still have a system, a healthcare system, that is passive. If a patient is sick, that's when they will come to you. But by the time a patient comes to you, they are too late in their patient journey. We need to find approaches that find patients much earlier on in their cancer journey before they even realize they're sick, or early on, which means we need to walk out of facilities and find cases closer to their homes. Or we need to rethink the way we are actually screening patients. We now have a mammography machine in Butara, and I've been making the case that maybe we need to have mammography machines in supermarkets. Because by the time you identify you have a swelling, by that time you have lymph nodes, you have extended disease, it doesn't really make a lot of sense. And people don't generally come to health facilities to see whether they are sick. They only come when they are sick. So we need to be able to either be more intentional and proactive in challenging people whom we think are at risk to actually get early screening. Most of us, for example, in this room, I would guess have insurance. But when was the last time you actually went for screening for cervical cancer, breast cancer, or any other cancer? We don't. We only do that when we start feeling some kind of symptoms. So we need to find a way in which we can mandate that either as part of health weeks promotion campaigns or other initiatives that can push people towards accessing these services, even when they are not feeling illness. But to do that, you need to invest in awareness, you need to invest in healthy living rather than just sickness-driven parameters. We need to also work with insurance companies to be able to extend these services as part of their responsibility, not as part of a business, to make sure that, for example, if I'm 50 and I'm going to check my eyes, I should be able to have also my prostate checked. If we can do that in a systematic way, I think we'll be able to capture people early on in their disease. Fourth is, I think even as we sit here and see all these advances, if we are not able to have strong advocacy, number one, to increase access to these opportunities, but also for them to be affordable, we will not make a lot of progress. We had friends come and share some of their modern solutions, but even if they offered that solution at the price at which that solution is produced at their companies, largely none of us can afford it. So then the question becomes, how do we really build an advocacy platform to be able to have access to those services at a much more affordable cost? Who pays that cost? I do believe that somewhere down the line, if you'd all agree with me, healthcare, education, water, these should be human rights. And if they are human rights, there should be someone who is mandated to provide that human right. We can then have other innovative ways of how those rights can be paid for, but as human rights, they should be accessible to all people. So as we deliberate in this conference, in these meetings, I hope we can look at, outside just what happens in a health center, look at approaches that can increase access, affordability, and optimal outcomes for patients and for communities. And for those of you who are here, I'll tell you that as you age, you're more likely going to be a client in this service, hopefully not soon, which means that we need to set up systems that will serve us in the next 10, 20 years. That's just a reality if you look at the epidemiology of cancer. So welcome to this journey of advocacy. Welcome to embracing equity as really an initiative that pushes our mandate, and welcome to improving healthcare systems so that we can fight against cancer. Thank you very much.
Now, today, I just remember when I was in school, we started with the letter A. So when I was hearing Professor Jack Maresco, he was talking about artificial intelligence. Then Dr. Fred talk about awareness, talk about advocacy, talk about affordability. So the letter A is in motion today. Let's give a round of applause to Partners in Health. Partners in Health, for the people who don't know what they really do, this is the main partner of the government of Rwanda, Ministry of Health. They've done a great job to partner the government of Rwanda in terms of Ministry of Health. Let's give a round of applause once again to Partners in Health for a great job they've been doing in Rwanda for the last couple of years. So now we want to go to the break, but before we go to the break, the speakers I'm going to call, they'll just do less than 3 minutes. We want to play a short video from one of our sponsors called Transfer Technology. They will be having the their video be played on screen. And to help us in the presentation, we are going to call upon Mr. Temel Ozuga from Electa to come and give us. Let's give a round of applause to Mr. Temel Ozuga.
Distinguished attendees, ladies and gentlemen, thank you very much for having us opportunity to be a part of the first E3 International Cancer Congress. We are very excited to attend this one, and also I would like to specifically thanks to Electa distributor and a sponsor of this great organization, TTR. So Electa is a Swedish radiation oncology technology manufacturer and since 1972. So we are providing and manufacturing the state-of-art radiotherapy solutions, and in this regard we offer wide range of technology. Of course, these technologies, in summary, these are linear accelerators that we currently have in 2 systems in Rwanda Military Hospital as the first radiotherapy systems in country. And also another technology and approach is the brachytherapy, which is a golden standard treatment modality when it comes to gynecologic cases. And also it's very important in the sub-Saharan Africa due to high incidence of the gynecologic cancers. And other than that, we do provide gamma knife technology, which is not only for the malignancies intracranial located, but also functional disorders and the vascular disorders treatments can be easily done with this one without an invasive approach. And also not the last but not the least is that the MR-Linac technology, which is a combination of 1.5 Tesla MRI and the linear accelerator that allows clinicians to see the tumors in a crystal clear so that they can increase the treatment dose and reduce the treatment sessions so we can treat more patients in a more effective way. So, and also the Electa's main approach is that to lower the barriers to access the radiation therapy for everybody. And as you all know clearly, radiotherapy is a big need and the gap when it comes to Africa. And also this is our company vision and the mission to help in this regard for the entire sub-Saharan Africa. And what I will say as a last word for this part, thank you again. As Electa, we are on your service, and we are very proud to bring these solutions, and also we would like to increase the collaboration and the partnership to providing the radiation therapy solutions to entire sub-Saharan Africa. Thank you.
Thank you so much. And we call upon the last speaker for this session, Noah from Paxera. Thank you so much.
Good morning, and thank you everyone for coming in today. I would like to express my gratitude for having us in the conference today, and I would like to thank our partner here in Rwanda, Transfer Technology, for giving us the opportunity to be present in Rwanda. We at Paxera, we are a US company, and what we're doing is we're offering radiology software solutions. And by offering radiology software solutions, what we do is we bring in the best practices that we have seen across all the countries we have worked in. Today, as we listen to different speakers, we have seen multiple points that we have already overcome in other countries. One of them was the one discussed by Partners in Health, where they were discussing that we do not want to help cancer patients. We want to prevent cancer happening. We want to reach out to patients. We want to help in early detection. One of the initiatives that was created in Africa was the Women Health Initiative, where portable mammographies went to women in district areas, in rural areas, to make sure that we help them in early detection. Allow me to give you a little bit of an idea about the radiology software solutions that we offer at Paxera and how those solutions align perfectly with the purpose of this conference today. At Paxera, we firmly believe in the power of AI. We believe that the potential of artificial intelligence, machine learning, and cloud computing is the way to revitalize how cancer is diagnosed, is the way to help cancer being monitored and treated. We believe that the potential of AI in the field of oncology is through leveraging on different algorithms, machine learning techniques. What happens is a large set of data can be analyzed in minutes. Instead of taking months to create AI algorithms, it can be done in a couple of days, using the data sets for each country and for each genetic formulation of each population. What we do is we're committed to developing innovative AI-driven solutions that aims at empowering healthcare professionals and hopefully contributing to a world where cancer is not only treatable, but preventable. As we gather here today in the heart of Rwanda, we are reminded by the immense potential of growth and progress in the African continent. We're committed to being active participants in the advancement of healthcare in this region. With conclusion, I would like to extend my gratitude for the organizers, and hopefully we will have the chance to communicate further during the rest of the time in the conference. Thank you so much.
Thank you, Noah. Thank you so much. This has brought us to the end of this session, and I want to thank you all. We will be going for a small break, just 15 minutes, then we come to the second session. Thank you. I want to thank you. We see you after 15 minutes. Exactly 12 o'clock, we are back, so that we try to compress the remaining session before the lunch. So see you. Thank you. Let's give a round of applause to all the speakers who have been speaking before. Thank you. Exactly 12. As we go out on the corridor, on our right side, that's where we get a small tea. It's just a tea break, 15 minutes. 12 o'clock, we are back. Thank you. Yours is what? ICQ. No, I'm sorry. Oh, ICQ. Okay, that's good. There is a guy who was in charge of the slides, and we must make sure that it's there so that we avoid the hiccup. I will make sure that I introduce you to the guy. Right. You see, let me go with you. Let me go with you. Here, let me go.
and with the option for local anesthesia. Utilizing liquid nitrogen, this fast, minimally invasive treatment is providing a IceCure believes in the power of choice. The power to choose tumor treatment with minimal to no pain, free from long hospital stays, and with the option for local anesthesia or light sedation. The power to choose cryoablation. Uniquely utilizing liquid nitrogen, this fast, minimally invasive
So we are presenting. I'm presenting next and back.
When you're ready, just
amashuri ntago azashira n'ahaza ubwenge ntabwo buraba buke
ariko zikari ubona kigutera tenya ukagabura se ngiye papasi yo kwiga ngiye ko papasi yo kwiga ari amafaranga
papasi yo kwiga ni amafaranga kandi urayafite
ntayo mfite cyore abantu ariko mu nsengero basanga ibyampamye ni ukuri
ariko amafaranga abantu barayashaka ni ibishaka ngo ntago amazi ariko ngo ntago ngo yemewe kwinjiramo hano amazi
ese n'ibi biti twicayeho muri iyo modoka
You press this when you want to
Thank you.
Thank you. In the next maybe 2 minutes, we'll be crossing over live to those who are going to be streaming on TV or online. So please, everybody, I now need your attention in the next maybe 2 minutes. We'll be starting the program. So to those who are outside, try to call him in Swahili because this man need no introduction. He told us how he want to be called. He has been here before. He is coming from East Africa. In their country, there is a lot of wild animals, beaches, and everything. Ladies and gentlemen, allow me to call Dr. Jerry Ndumbalo to the stage, who is the founder and president of Tanzania Oncology Society. Dr. Jerry, come to the stage. He's our first also panelist. Then on second, I want to cross over to Israel. You know the way I fly the plane from Tanzania to Israel. I want to call upon the VP Business Development and Sales in Medical Technology. You know, when you talk about technology, we are talking about Israel. And we are privileged today. We have got Mr. Noah Sorek, all the way from Israel. May we give a round of applause to Mr. Noah Sorek, Noam Sorek. Then, without wasting much time, I also want to cross again to the person. I think I'm playing with the technology today. Mr. Professor Ozug Temel from Electa, the regional manager, to come to the stage. Let's give a round of applause to Professor Ozugu Temel. Thank you so much. Then we are so privileged today to have the epidemiologist and the senior data scientist. This man, I've known him, but he didn't know me. He doesn't know me, but I know him very well. Ladies and gentlemen, I don't know if he's the one who owns Remera here in Kigali. Allow me to call Dr. Eric Remera to the stage. Whenever you see Remera now, know the owner. Thank you. Let's give a round of applause to the owner of Remera to the stage. We are so privileged today. This man who is coming again to join the panelists. He is not usually in one country. He moves from one country to the other, and to the other, to the other. And we try to squeeze in his tight schedule. Ladies and gentlemen, this man has been so instrumental in the healthcare. I don't want to explain more. You will hear when he comes. Allow me, ladies and gentlemen, to call upon Mr. Brian Francisca to the stage. Thank you. Let's give a round of applause to him. He always travels a lot. I always meet him most of the time in Dubai or Mexico. Now he's in Kigali. Welcome to Kigali. Ladies and gentlemen, I want to call upon the moderator of this session. You have seen him, you have seen her, and she doesn't need no introduction. She's the founder and president of International Health Consultancy in the USA. Ladies and gentlemen, help me to welcome our moderator, Dr. Senaid Kebed, to the stage to lead us in the next session. Thank you. Let's give it another applause as she takes the stage.
Thank you for all these introductions. We will start our panel discussion. In the interest of time, we will not make introduction of the bios. I hope you are familiar with our speakers by now. And I will apologize also. I may call people by first name to move things fast, and I'm just declaring this ahead of the discussion. We will try to go through the three main discussion areas, which we're starting with the strategies of improving cancer care in limited resource areas. A few of our panelists have presentation. We're gonna limit that to hopefully 5 minutes. And after they finish their responses to the areas of discussion that we will be having subsequently, we will open the floor for discussion. So you may want to note your questions, and that will be dealt with once we are done with the three main areas of discussion that we have for the panel. So again, it's good to welcome our panelists. The first question or area of interest that we would like to explore is the strategies for delivering effective cancer care in regions with limited resources. And the focus would be on innovative and cost-effective approaches. So the question is, what are the low-hanging fruit and what innovative strategies would you focus on if you had the option to influence policy and strategies in countries? So the first speaker is going to be Mr. Sorek.
For IceQ. Yeah. So thank you so much for inviting me for this very important conference. My name is Noam Sorek, and I'm working in IceQ Medical. And in IceQ Medical, we are, in general, freezing cancer in its tracks. We do it globally around the world, and hopefully from now we're gonna do it also in Africa. So IceQ Medical is an Israeli medical device company founded to advance treatment of tumors. I would like to present you a quick video that explains in 1 minute about cryoablation and what we are doing. Can you play, please?
Or to choose tumor treatment with minimal to no pain, free from long hospital stays, and with the option for local anesthesia or light sedation. The power to choose cryoablation. Uniquely utilizing liquid nitrogen, this fast, minimally invasive treatment is providing a new alternative for patients and physicians worldwide. freezing away benign and/or cancerous tumors, with promising interim results for small, low-risk breast cancer and 100% satisfaction with cosmetic results as the breast remains whole. It can be performed under local anesthesia or light sedation in less than an hour, with little to no pain or discomfort, minimal to no scarring, and rapid recovery. Now you can freeze your cancer, not your life. Cryoablation by IceCure. It's your choice.
Okay. So our mission is to create new choices in cancer care for physicians and patients with minimal invasive cryoablation procedures. And in general, we would like to create the awareness, mainly in Africa, for alternatives for surgery. Not everybody has to go through surgery, and there are alternatives. So our presence around the world, as you see, this is the blue colors, and what is coming into your mind, I think, in the first sight is that Africa has no presence. We have some activities in South Africa, but I hope to come here in a couple of years and to start seeing some blue also in Rwanda and, of course, in Africa. We have just 5 minutes, so I'm not going to go over it. I think the best is to show you another video to understand more about cryoablation. Would you please play it?
IceCure Medical's ProSense cryoablation system destroys tumors by freezing them. The minimally invasive procedure uses a needle-like cryoprobe to create an ice ball around the tumor using liquid nitrogen in a close-looped system. Cryoablation is performed in an office with local anesthesia in less than an hour, with rapid recovery, significantly lower cost, and great cosmetic results compared to surgery. The ProSense system can treat tumors in the breast, kidney, lung, liver, and be used for other treatments in interventional oncology. IceCure's ProSense, the next frontier in cancer treatment.
Okay, I'm not going to go over this. We don't have much time, maybe later on, but in general, the system is doing freeze, thaw, freeze. This is the best option for destroying the lesion. And this is the cryoprobe. You can see in the middle, the cooling zone center, minus 170 degrees, up to going to minus 20 degrees. The whole lethal area is the area where the lesion cannot live after this procedure. Let's keep going. We are using liquid nitrogen. If you see the green line going down, it achieved a rapid temperature decrease at the beginning of the freeze procedure, which is very important for the destroying mechanism of the lesion. And throughout the whole procedure, it's very stable, low freezing temperature, which is very important as well. Just quickly, the difference between cryoablation and thermal ablation, which are more popular here in Africa because it's a bit cheaper, but there are some main advantages. First of all, pain. There is minimal to no pain with cryoablation. When I'm playing football and I got injured, they are coming with this spray, freezing it, and the pain is gone. With thermal, it's very painful. Then it brings us to the fact that you do not need anesthesia. Just lidocaine, and the patient can go through the procedures. Visualization. You can see clearly the boundaries of the ice ball. And this is very important when you do it with ultrasound or a CT, because you know where you are and not to damage any essential organ or make sure that you are doing the right things. With a thermal, there is vapor and you cannot really see. Another important thing is the immune response. We know today that cryoablation stimulates the immune system, and it's getting better and better, and we can elaborate about it afterward, but we have some studies that prove it. This is just, you can see here on the left, the thermal ablation, where you do not really see where you are, compared to the very good visualization of the ice. How long I have? Okay. Challenge in breast cancer surgery. Breast is a huge thing here in Africa, and in terms of cost, I know each market has its own characteristic, but it's supposed to be cheaper. Cosmetic outcome. There is no loss of volume, shape, no scars. Re-excision. 1 out of 5 patients undergo re-excision after lumpectomy due to unclear margins. It's a big number. Recovery time. 1 hour, 1.5 hours, and the patient can go cancer-free from the office. And use of operation rooms place an additional strain on the hospital. We give value for all. I'm not going to go about all those values that we give to the patient, physician, insurer, and the healthcare provider, but I can send you later on. We, IceCure, did the largest study ever been done in the world for breast cancer treatment with cryoablation with 194 patients with 19 medical centers throughout the US, and the results were amazing. 96.91 recurrence-free. It's better than lumpectomy, with 100 satisfaction from the doctors and patients. And I'm glad to say that last week we had the last patients for follow-up after 5 years, and we just published it last week, and we are very proud. I'm not going to go over this. This is independent studies confirm the study from Italy and Spain. We also work in IR, in kidneys, lung, bone, liver, also for women's health in the endometriosis. Endometriosis is a chronic, a very painful disease for women, and we give them a great solution for pain and for not having to have another surgery. This is the last slide. Just to show you that we are backed up by studies for all the indications, for endometriosis, for kidney cancer, for lung cancer. By the way, this is done by Dr. Nomori from Japan. For lung cancer, he proved that 77% up to 100% recurrence-free rate depend on the lesion side. That's it. Thank you so much.
Thank you for your presentation, and we've heard about this innovative approach. Its comparison with the traditional approach of thermal ablation, the advantages and how it compares in terms of pain, inducing immunity, and others, and also a study that really gives the data to inform us about how effective it is in preventing recurrence. Thank you for that. So the next one is going to be Brian. If you can talk a little bit on innovative strategies.
Thank you very much. I'll expand on this a little bit later in my talk. But one of the things that the gentleman from Partners in Health was talking about, he used the word systems 10 times. And one of the things that I've noticed over my 30 years international work and then time before that in the US is we tend to not think in systems. We tend to think in very vertical, isolated, I'm going to build a hospital, right? Or there's an insurance, there's a payer. And if you look at, an innovative strategy, and it may seem like common sense, but we tend not to do it. I live in Dubai in the UAE. We do not have a national healthcare system, right? We have 4 different regulators, right? So one of the most innovative things I think that most countries can do, especially when you're in a situation where you're creating, you're developing, is to really give a lot of thought to approaching everything as a system. And I'll expand on this a lot more later.
All right. Can we move on to the next one? Oscar? Thank you, Brian.
Sure.
You will expand later on.
Thank you very much again. My name is Özgür Temel. I am Elekta Sub-Saharan Africa Regional Manager and also medical physicist by profession. So today, actually, my entire career is on radiation oncology, and today my main focus will be what are the gaps and the needs when it comes to radiation oncology in Sub-Saharan Africa, and what will be the potential mitigation strategies to fill these gaps and address the needs in radiation oncology site. So I do have a short presentation to summarize these points. Right. So, as you know, the cancer is a global problem for us, and what we see is that world population is growing 1% every year, where the cancer incidence grows 2% every year. So in this regard, we can say cancer becomes a new global pandemic for us. And also, when we look at the access to radiotherapy systems, according to World Health Organization recommendation, every 1 million population should have one linear accelerator as minimum. So if you look at North America, every 1 million population is 12. Europe, it's 5. In Asia, where we have two most populated countries like India and China, 1 million population is 1 LINAC. So let's come to Africa. We have 0.3 linear accelerators for every 1 million population. So if we zoom in the Africa for this distribution, this is the information table from IAEA records. So the North Africa and the Southern Africa, they meet the minimum recommendation number. Every 1 million population has slightly more than one linear accelerator. But if we look at the Middle Africa, where we see is that it is 0.08 per population, per LINAC per million, and where we have almost 1.1 billion inhabitants where they live in. Obviously, radiotherapy access is a big gap in Middle Africa especially. So, of course, regardless of the machine, we definitely must have a competent clinical team. And when it comes to radiation therapy, we do require a multidisciplinary team, including radiation oncologists, medical physicists, and the therapists. So here what we see is that because of lack of the clinical oncologist number in Sub-Saharan Africa, per oncologist may deal with more than 3,000 patients. So we also need to invest for our future for the competent human resource. So what will be the mitigation strategies for the lack of radiation oncology access? So one of them is that I strongly believe that the public insurance should be in place for the private institutions. So this is an example from Kenya. The NHIF provides a reimbursement for the private institutions per patient. And also in my country, I'm from Turkey. 15 years ago, we used a very limited amount of the linear accelerators. But since public reimbursement comes into place, today Turkey has more than 200 linear accelerators in country. So this public reimbursement encourage private hospitals and their investors to invest on radiotherapy, and then knowing that they will be paid by public insurance. And then, depending on their targeted patient group, they can request on top of it. But even they don't top of it, there is a guarantee from government that they will receive payment from for the patients that they treat under the public insurance. So it will be a good driver for the private investors. So partnerships is key. To increase the capacity. So here the public sector should be a driver and the regulatory body, and as well as a guarantor for the investments. And the private sector should bring in with an investment, both for the construction and equipping the centers, and as well as bringing the human resources when needed. And of course, the vendors. Vendors definitely democratize the access to radiotherapy by offering the good pricing for sure, because the equipment that we are talking here requires heavy capex investments, and as well as bringing innovative financial solutions. And this is in Elekta what we are exactly doing when it comes to financial solutions. And also as a vendor, we provide comprehensive training and education, and as well as service maintenance for our equipment. So in Elekta, we are not supplying the equipment. We are providing a package solutions that address the needs. So by combination of the public sector, private sector, and the vendor, this is where we can get the magic and get the things done. It could be a mitigation strategy. And on top of that, we definitely need a competent team, as I said. So in this regard, teaching hospitals, universities should definitely open a training and education programs for medical physicists, radiation oncologists, and RTTs. So today I'm so gladly and heard that the Muhimbili University in Tanzania is opening a medical physics program. So it really helps to fill a gap when it comes to medical physicist needs. So definitely we should do that, and in Elekta we are more than happy to support such kind of residential programs, educational programs by all means. And of course, modern technologies help us a lot to fill this gap. So one of the technology in Elekta, the linear accelerator, what we call is Elekta Harmony. The beauty of the Elekta Harmony, clinicians can able to treat the patients within 8 minutes, just 8 minutes. 8 minutes patient in and out room time. So if you run your, so in 1 hour, you can do more or less 8 patients per hour. If you run your Linac 12 hours, you can do almost 100 patients in single shift every day with single unit. So this is, and also it allows you to deliver the IMRT, 3D, conformal, even up to SPRT treatment techniques efficiently with a very limited time slot. So this is also a great workhorse system, and also mitigate the need, because most of the linear accelerators in the public hospitals, they are treating more than 100 patients a day. So for instance, the Elekta has a Linac at Keynote National Hospital. The machine treats 110 patients every day, every single day, and the waiting queue is 6 months, which is not acceptable for cancer patients. So such kind of technologies really help to increase the patient throughput. And of course, another technology that should be considered is the gamma knife. With the gamma knife, it allows you to treat the stereotactic radiosurgery intracranial, and as well as the vascular malformations and the functional disorders with a non-invasive way. So if a patient goes into an operation brain surgery, the patient needs to be hospitalized for 3 to 4 weeks, and also there is another recovery period. And if the patient is the breadwinner person of the family, it will create a financial burden. And also it will create a financial toxicity even for the patients and the family. But with this non-invasive stereotactic treatment approach, same day, patients just discharge from the hospital and they go back to normal life next day. So, and also such kind of technologies helps a lot for the socio-economical burden. And of course, there is a lot of emphasis doing this software development and remote connectivity. Of course, in radiation therapy, there is a big implementation. Definitely, we should establish satellite centers. Most of the capitals in the sub-Saharan Africa, they do have a radiation oncology departments, but the other cities, surrounding cities, they don't have. And the patients need to travel long distance, and they need to stay in these cities for a quite long time. It creates another financial problems and the discomfort for the patients. What we can do is that we can establish a satellite centers and connect to main center as a command center, and this main center can do treatment plans and monitor the workflow remotely. So it reduced the need for the number of the medical physicists in the satellite center, which is where we are lacking. So this remote connectivity help to reduce the need for the medical physicists in the satellite center, and also these technologies should be in place. So this is, in summary, from my talk, how to mitigate the needs and the strategies for the radiation oncology. And I thank you again and again for giving us a chance. And what I believe is that in Africa, of course, okay, today we may have some challenges, but I strongly believe the Africa and its potential, and Africa and the future is bright. We definitely win this fight against cancer. So I'm so hopeful and so grateful to be partnering with you. Thank you again.
So thank you again, Oscar. We heard new terminologies and services that can be useful. The Electa Harmony, Electal Gamma Knife, and how this can be used to reduce the burden of socioeconomic status for the cancer patients with low downtime, efficiently treating more people at the same time. And we will ask so many questions later on.
Pleasure.
How cost effective it is, whether it's feasible in rural areas. Pleasure. And you did mention a very important aspect, creating satellite centers with remote connectivity and integrating these services. And Brian had already talked about systems. Creating the systems is a very important aspect. This brings us to a good transition to ask Dr. Jerry to the next question in the panel discussion. I'm sorry. So let's go to the next question, and maybe you can start by following up the presentations that were done ahead, and we will talk about collaborative research in Africa. You can say a few things on that.
Thank you. Research. As I said in my presentation, whatever we are doing, you cannot plan anything without data, without information. WHO published in 2018 that there were 13,157 research in North America. And this was 30 times the researches that were done in sub-Saharan Africa. So you can see how low the research output on our area is. So first we have to prioritize, because even the researchers that some of them we are collaborating and doing them, probably they don't answer the questions that we have. So the main thing probably I will start with, we have to identify our African research topics. We can start from incidence and mortality, because as we can see every year when they publish about the incidences in especially sub-Saharan Africa are rising every year, and the projection is we're going to have 1 million patients in 2030 and probably 2 million cancer patients in 2040. So we have to know exactly what are these risk factors that are around in our areas. We have to know our genetic profiling. We have to know molecular and biological effect that is around here, and then translate on what we can do in terms of from prevention, treatment, and also care. And also we need to have research on implementation science. This is a very new area that most of us, we are doing programs, but we are not assessing them. We are not doing the science on how to implement. Especially most of our countries have started the HPV vaccination. I think almost a lot of African in sub-Saharan, they've started doing it. But how are we getting value for money for it? But because we are expecting probably in 10 years, 15 years time to have this cervical cancer burden reducing. So how can we do these implementation science studies in order for us to compare the costs of treating this cervical cancer patient, comparing to the cost of investing in vaccination of these girls, and then translate and see the difference in terms of the economics of it, and then present it to whether the government or anyone who is basically involving in funding. So we have basically to have this implementation science. Of course, we have to have clinical trials, and most of these clinical trials is partnership and collaboration with other Western countries, US, UK, Europe, but we have to know the efficacy of these drugs, because very few studies they've done to check on these chemotherapies that we are giving, targeted therapies that we are giving, even radiotherapy. To check are the doses same when I give this dose to a Chinese and an African, or a European and an African, in terms of, because as we said, we are different in terms of genetics and even the environment. So clinical trials in terms of efficacy, toxicity, and the dose has to be in place in Africa, and this is mainly can be done through collaborations. And non-therapeutics now, non-clinical trial like psychological, survivorship, palliative care, we need a lot of this in our setting, more than even the clinical trials, because these are the patients that we are saving, almost like 70 to 80%. So we have to also talk about the financial burden that is there. We have to look at it in detail in a way that we can support these patients during their treatment. So non-therapeutic trials, they have also to be emphasized. Now, what can we do in terms of now? We need infrastructures and resources, the lab space, the equipment, the reagents. As you know, most of this clinical trial that will require. So that is the area that we have to partner between institutions, all the partners and stakeholders, from the pharmaceutical companies, from the tech companies, to come together and mobilize resources so that we can have answers or researches that are basically based for our consumption. The last one I want to talk about also is the workforce. I will be repeating about the workforce in research. Most of our clinicians or doctors, most of our doctors, I can say, they are clinical oriented. They are not research oriented. So it's very difficult to find a surgeon involved in research in Africa. But it's part and parcel of activity when you are in US. You are a surgeon, you are publishing almost every day. Whatever you are doing there is information. You have to give it out to. So we as Africans, especially clinicians, we have to change that mindset. How are we going to change? It's basically also through training and exposure. So through these collaborations with inside and outside Africa, within ourselves, we have to at least pass this information, pass this knowledge to each other, so that we can have workforce that is not only clinical oriented, but also research oriented. So that's all I wanted to talk about collaborative research in Africa.
Thank you, Dr. Jerry. I think this will take us to the next speaker, Dr. Eric. Dr. Jerry has highlighted that the region lags behind when it comes to research, and we need to pick up the pace there. And priority for African research in cancer should be decided. That would guide us to see what kind of incidence rates we have with the different kinds and risk factors. And then implementation science should be promoted, as well as workforce development, with a focus on making clinicians related to research and increase research capacity through training and networking across African countries. And I think this is a good segue to Dr. Eric's presentation, who is the epidemiologist here at IRCD.
Yeah. All right, thank you very much. I thank my colleagues for the good presentations, and mine will not be much different. I will equal to what my colleagues, especially Jerry and Jack, presented. And first of all, as we heard, we've seen that like there was globally, there was a decrease maybe in cancer mortality in high-income countries. And we are now seeing an increase in cancer mortality in like low and middle-income countries. So this can be due to different facts, and that will not repeat here because of the time. But this increase is also give some task to ask about what can be done. So, sorry. So as now, the first thing, in epidemiology, the first thing to do with the detection, and as now detection rates and therapy success increase in high and high income countries, it's now predicted that like in the next decades, more than 75% of cancer-related death will occur in low and middle income countries. This gives another reason why to invest much in Africa and why Africa needs now to take the lead on the cancer. So when it comes to research, we know that like the pyramid of evidence starts from maybe from an idea to cross-sectional studies, and maybe the high ranked will be the clinical trial. But when you look at different studies that are conducted in our continents, we are seeing few clinical trials, we are seeing few digital solutions. Maybe if you can see from the presentation done by Jacques, we've seen that there are many studies conducted in Europe, in America, in Asia, but like the only thing that we had in Africa was the launch of IRCAD Africa in the last 6 months in Rwanda. The same with my colleagues, like all those colleagues, ISQ, there's nothing in Africa except in South Africa. So still, Africa needs more research. We need, as now the epidemic is increasing, we are in need of more evidence, and we need more studies. We know that the future is bright, but when we look at what has been done so far in Africa, on different countries, the only thing that is done is some like understanding the epidemic, the trend. So like these are data from Rwanda showing like the increase in the diagnosis. You may say that like from this slide, that maybe you are getting more people who are like more incident cases on cancer. But that's not true. The truth is that like from the beginning, like when we started our cancer registry 15 years ago, we had low capacity to detect all the patients with cancer. And this can be demonstrated through this map. Back in 2009, when this have started, we could identify people from only few regions of the country. And as we've been maybe scaling up the treatments, getting more sites, more hospitals, more workforce, clinicians, we can see that as of now, like we can detect all the patients across the country. So this means at least the country has done some efforts to detect and to diagnose patients with cancer, and we are able to detect like any cancer in countrywide. So, but as I said, we are still at the phase of understanding our epidemiology. And the same here, we are still at the phase to know which cancer do we have the most, and which age group is suffering more by gender. So now, as you understand from the presentation that we had from Jacques in the morning, it was to like high technology and how high technology is used to treat cancer, and the same like we had from different companies here. So now we can understand like the journey is still long to to know, to use the technology and to have more advanced research. So we have some challenges. Some were said by my colleagues. First of all, is about lacking of ownership on research. So we know that like sometimes our research agenda is driven by external funders, depending on how much they have and where they need to invest. We are still having a low capacity in research and developments, like including training facilities and how we can also return our talents. Sometimes our talents go back to Europe or to America and we cannot return them on our continent. Infrastructure is still a challenge, and my colleagues Jerry talked about this. And we are not able to conduct like some experimental studies, even some also to take some images that can help into diagnosis. So sometimes also our efforts are very fragmented. Here we can say even in East Africa, we are not able to know maybe what's happening in Tanzania and how can we collaborate. So this is a slide that shows about research collaboration. And you've seen that like maybe this is not only cancer, but it's research in general. You've seen that most of African scientists, they are collaborating more with European and Americans than we are collaborating between ourselves. So that's a challenge, and this maybe it's urged more collaboration and advocacy, how Africans can collaborate between themselves, share what they have, and make a big team. So as I said, the future is bright, though there are challenges, but there are also some opportunities that we can explore in Africa. As you said, when Jacques presented, he was saying that there's some cancer that maybe they're not able to test, some surgery that they can do in America or in Europe, but they're doing it in China because they have more cases. I think also in Africa, we still have cases are rising, and that's also like an opportunity to increase research, which will help into reducing the cases and will also help in treatments. So there's a political will, and we're seeing that some universities and pharmaceutical and biotechnology institutes coming in and now increasing, and that's also an opportunity also to increase research. Now, we know that we are targeting, like when you look at the growth of biotechnology and pharmaceutical markets, it increased, like there's a projection that it will increase, like the fund coming from those institutions, it will increase almost double by in the next 8 years. Also, we know, like maybe giving some example, that like now, not because I'm Rwandese, but we're not happy to see that now Rwanda is hosting the BioNTech and we're having also Alma having their regional office in Rwanda, and IVI, which have started, and now we have CDC Africa, which is there to support all our continent initiatives, so that research can be improved and the public health as well. So as a conclusion, we can also say that we have many challenges, but we are still believing that the future will be bright. We should increase the collaboration and also to address some gaps, including infrastructure, workforce development, access to medication diagnosis, and preventive measures. And research should follow all of those and also be part of those initiatives. Thank you. And thank you for your...
Thank you, Dr. Eric. You brought up a very good point in the fact that there is increased cancer being reported, incidents being reported in Africa. And this could be due to increased detection rate and probably not necessarily just increase in incidence, but we may be detecting more because we are doing more to find and treat these cases. So the other point is that he was able to demonstrate that there is very little collaboration among African countries, but most of the collaboration are with the Europe or America investigators. There's nothing wrong with that, but the point is if we had a collaboration among ourselves, it creates a more conducive environment for the research ability to be, the capacity to be improved locally, and also the ease of connection, which would make things faster, and ownership of data and ownership of the research itself may be easier because there is not too much leverage when it comes to ownership of the data and ownership of the research itself when we depend on external funders. That calls for local investment, and I think increasing local investment without a doubt is a very important strategy that one needs to think about when improving cancer care. So let's go back to the last section of our panel discussion, and this one is looking at the international collaborations. So I would like to start with Brian or Dr. Jerry to start commenting on the international collaboration in cancer, in research activities and partnership to advance cancer research on a global scale. Let's say something about the global scale. I think we have been focusing more on the regional aspect, but let's touch upon the global scales briefly.
Thank you. I will still insist on research infrastructure. As I said before, most of these infrastructures, especially when you want to answer questions, especially in clinical trial, need partnership not only in sub-Saharan Africa, but also with the rest of the world. And knowing different patterns of this disease as well is also very important to collaborate in different regions. So let's say colorectal cancer. I'm doing a PhD study in colorectal cancer. The burden is rising now in Africa, especially in sub-Saharan Africa. And the pattern now is on very young generation, around 20, 30, sometimes even to 40. The picture is totally different the past 10 years that we are only getting the old ones in colorectal cancer. So knowing the genetic pattern, comparing it in sub-Saharan Africa, comparing it with the Europe and Asia, and see how we can know exactly how this the disease presents is very important. So collaboration is not that only important for the infrastructures and the resources, but also this data that you can get because of different pattern, especially in terms of genetics between the other regions. So it's must to have these researches that are beyond only in sub-Saharan Africa. Even in the drug development as well. As I said previously, the toxicity, the efficacy, and all that has to be not only in one region, at least to have a global to answer the question globally, so that you know the same drug can act differently in different settings. So if you have a trial, if you have collaboration that caters for all these regions, especially different populations, Asians, Africans, Europeans, and then you will have answer that probably it will help not only in treating our patient, but even in the development of the drugs, all these new targeted therapies that are developed. They are very, very important for us to use for our patients. Workforce also, as I said, in sub-Saharan Africa, the workforce is inclined to clinical rather than research. So partnering globally knowing what is the other side doing, like what Prof was telling up here in terms of the AI. We need that global collaboration so that we can have a global knowledge or global technology, but convert it and treat local patients. That is what is important. You can have a global information, global knowledge and all that, but if it doesn't translate directly to our patients, then that will be just a kind of just a luxury in our setting. So in these collaborations as well, these researches has to translate directly to our patients in terms of the outcomes. Yeah, those are the things that I can point out.
Thank you, Brian.
Thank you. I started my international journey 30 years ago working with the Johns Hopkins School of Public Health. And over the past decades, I've worked in various different, on both sides of the table regarding partnerships and collaborations. I've been on the provider side, whether it's Johns Hopkins or Cedars-Sinai out of LA, but then I've also been on the recipient side. I worked with Dusit Medical Services in Thailand for many years. So we were partnering with European and American organizations. The one main comment that I really need to make, and is really important, is on one hand, and we've heard this several times, we need to hurry up. Right? We're behind. We need to hurry up. And I get it. You need to hurry up. Everything should have been done yesterday. At the same time, regarding these international collaborations, you need to slow down. Because I've seen more often than not, people are in such a hurry to get into one of these international collaborations and to sign the agreement and to do the press release, and then 18 months later, it's blowing up because it's failing to deliver on expectations. So yes, hurry up, get on it, and plan them. But then, before just jumping into it's just like getting married, right? Do some dating first. Really do some due diligence. Really plan. Understand what you want and need out of that relationship, because it's not just. I know, for my professional career, it may look great, me signing a deal with Johns Hopkins and going to Baltimore and all that, but it may do nothing for your patients, right? So really understanding what you as an individual, what your organization, what your country, and most importantly, what the patients need out of that relationship, and write it out crystal clear. Go to ChatGPT, get some help with that, you know what I mean? But make sure that when you're looking for those international partners, you are crystal clear in what you need and how you're going to quantify that it's delivered, right? Because that's so important. Yeah, that's all I got.
Okay. I think these are very important messages. Yes, we need to collaborate among ourselves, but also globally. It's not only for their infrastructure or funding that we collaborate with others, but to have a deeper understanding of the disease, the risk factors, and the responses to drug treatment and therapeutics. It becomes relevant to see what the research provides in terms of data that will inform our clinical practices and our measures in planning and policy information. And I think the last one by Brian, it's good to have international collaboration or even regional collaborations, but we have to contextualize what we are getting into. We have to understand what the benefit is for our patients, for our scientific growth, for our patients. We have to clearly know what we are getting into in terms of what advantage that will come out of this collaboration, how far it will go, whether it's ethical and it's sustainable, and the result is going to be informing our policies and practices. So having heard from our speakers, the floor now is open for questions. Yes.
Thank you so much, our speakers. I have 2 questions related to research. I would like to understand if there are opportunities to do the type of research that will inform the government on the benefits of expanding the diagnosis. I'm looking at the statistics, they are quite worrying that in the next few decades, the cases will increase by 75%. Looking at the health sector budget in East Africa, the curative budget is quite high. And for me, I feel like it is necessary to invest on preventive. So are there researches that will help to inform the governments on the benefits of expanding the screening services? I come from Tanzania, and that is an area that really needs to be strengthened. I'm happy that Aga Khan, they're going to establish a project to do the services, but I think that is not enough. The country is big, and we need government-owned facilities. So maybe in this type of researches, they will be beneficial so that our decision makers can draw from best experiences in other parts of the world to strengthen this and reduce the curative budget in future. And I also have a personal question. I lost family members due to cancer, and I also have friends who are suffering currently. And I would like to understand from the research perspective the role of herbal medicines for cancer care and treatment. I think there's a controversy somewhere, somehow, because some patients would prefer to opt for the traditional way. And in most cases, they are told to go for, not to opt for the modern way of cancer treatment, because the two type of treatments, they cannot be managed at once. So you will find patients run to the traditional way of managing cancer. And at the time maybe they are very serious, sick, then they would go to the hospital and it is too late. So are there researches that have been done on the role of herbal medicines on cancer? I think I'll stop there.
Yes, thank you. So who would like to respond to the first? We can have two people responding, one person for the first one.
The first one, briefly, but not from the Rwandan government side, obviously. But
Okay.
when I first moved to Abu Dhabi, I was working for Johns Hopkins, running Tuam Hospital, which is the regional cancer referral facility, and all of our breast cancer patients, all of them, without exception, were coming in end stage, stage 4. They were. We would do surgeries, we would do chemo, we would do radiation, we would do everything, and then they would die, because it was too late. There was no screening program. That was just a very unfortunate reality. We met with the government, and there wasn't research, as you were talking about the cost, to the government, whatever. But fortunately, they let us. I rolled out a mobile mammography unit around the Emirates. We started finding early breast cancers and treating them earlier. Now, unfortunately, we didn't baseline all this. We didn't do, but the amount of money that we probably saved the Abu Dhabi government over 10, 20 years is probably huge, in addition to the other benefit of saving all those lives. So the kind of research you're referring to, it should be done. It is needed. Maybe someone from the government side will have more to say about that, because as part of looking at a national cancer system and looking at the aggregated cost of care, the earlier you catch the cancers, the benefit obviously to the patient, but then the lower aggregate cost will be on the curative side. So that kind of research should be done, and I hope you get to do it.
Thank you. Dr. Eric, you wanted?
Yes, thank you very much. And maybe coming a little bit on the first question, I remember that Dr. Katera in the morning presented about the health system and how the prevention should be given a priority, especially for the diagnosis. And he was saying that even some diagnostic tools should be scaled up to the population. And research is there to even compare like the cost effectiveness of early detection versus waiting to be diagnosed at long stage. And this should inform the policy on how we can invest in the diagnosis. As you said, that was a projection, but if prevention measures can be done now, maybe that number can be reduced. So I think prevention is a major thing, and we need, again, research to demonstrate what we are gaining through that research and how many infections can we avert, and in terms of costs, what are we gaining? So in terms of herbal medicine and traditional medicine, I think, as you said, we are still lacking evidence. And given that we don't have evidence, we can't even recommend to go for herbal. So that's why, as my colleague Jerry said, we need to invest in more research and also to drive our research agenda. Maybe herbal medicine can help, but who knows? What's evidence? Nothing's there. Thank you.
I think I would like to follow up on the prevention. Another area that is also being looked at is the contribution of our lifestyle and habits, like alcohol is one of the oncogenic substances. Maybe those are some of the low-hanging fruit for countries to make sure that they study the burden and see behavioral modification as a way of prevention of cancer. Regulation of environmental toxic materials. Again, in Africa, we have very little regulation as to any companies or any products that are circulating in the market that may be toxic and carcinogenic. So these are some areas that are really playing a role in prevention, and that can be tied to the research question as well. Next question, please.
Thank you very much for a great presentation and very informative. My name is Vestine Mukeshimana. I'm the Country Director for Water Aid Rwanda. I would much appreciate the approach of system approaching of cancer management, and maybe follow up with Brian. Where do you think the system is having quite more gaps? I trust the cancer management is actually focusing on the middle part of it. It starts in families, communities, and the patients will always come to the doctor from their homes and go back eventually, if not the last days of their lives. But who do you think inactive players, for instance? What are those building blocks of this system do you think need also attention? To me, I think we are only tackling the very, very small point of the system, but I need to learn from you. I know you may have explored it already, but I trust, I believe in that system strengthening or system building approach, but I need us to hear more what you think when it comes to this strengthening the system approach you mentioned. Thank you very much.
Thank you. Brian, can you take it?
Thank you very much. You are going to hear a whole lot more in about 30 minutes, because I have a talk, I think, right after this called Talk Show, and it's going to be how Rwanda can establish one of the best national cancer services on earth. And it's about exactly that. So hold the question, and let's go through that, and then we can talk all during lunch. But it is the question.
One last question, okay.
So thank you so much. My name is Pacific Hajanimana. I'm from Partners in Health. As we have seen a lot of technologies going on around the management of cancer and detection, and also as we've seen from research that from the lower and middle income countries, we have high prevalence of cancers. So I would like to ask really what are measures you have in place, at least to ensure that those technologies are accessed and available, especially in the local communities. Thank you. I would be better if maybe one from the technology can answer, and also the perspective from RBC to see what the country is planning to ensure that everyone is accessing those high-level technologies. Thank you.
So maybe I would like to take this question, and thank you very much. It's a good question indeed. Definitely, in order to make these technologies and the treatment, not the technology, let's say, available for all our patients, definitely what we can do is that we should start with governmental bodies and authorities, so that they can initiate investment, or at least prepare the ground to attract the investors as the private investors. And then this project also should be backed and guaranteed by government, so that it will be affordable for the patients. So in this regard, there are good examples that we see in one example in Kenya, another one, Turkey, or some other countries as well. If the government put in place reimbursement for the private players, then it will really increase the number of these services, and also reduce the initial investment cost for the ministries, because the private players will do that. So with this setup, it really helps to make these treatments available. And of course, on top of that, the vendors like Elekta here definitely bring in innovative financing solutions, both public and the private players, that allows them to pay over long years period of time, like 4, 5, 6 years payment terms, so that it will create such a business setup. I don't want to say business, of course, but eventually it's a payment, okay? So that the system can pay itself in an affordable way, and they keep these things in country, because when the government or the ministries send their patients to overseas for treatment, it will cost them a lot. It will cost them a lot. Maybe one information that I may share: Kenya every year spends $120 million for their patients to be treated overseas. So if these treatment modalities exist in country, so we keep the money in country. So and we keeping the dollars, which is quite valuable where the dollar is a big shortage. So in this regard, I would say the initial leadership and the championship should come from ministry and the government. Then the rest will come.
Thank you. In the interest of time, we will stop here. Thank you all panelists for creating a forum that is really informative and responding to the questions. Since we are here, I'm sure you will have a chance to interact with the panelists if you have more questions. But because we have to finish on time, we will end our panel discussion here. We heard that we have a challenge, but progress is being made. Networking and partnering and collaborating within the region as well as globally is very important, and investing in workforce research and technology is another important area that we need to focus moving forward, and locally mobilizing resources is a critical part of that, including the political will. Thank you everyone for your attention.
Thank you, everyone. Dr. Remera, Dr. Professor Ozug, Brian, I'll ask you to remain on the seat. Dr. Sorek, Dr. Jerry, I thank you. Maybe you can take your seats. I just leave Brian to help us on the next topic. Brian will be speaking to us in the next maybe 15 minutes, then we go to lunch. I know everybody is not hungry, I know. So Brian, please, just bear with Brian. He's just going to do a talk show, maybe 15 minutes or so that exactly 2 o'clock we go to the lunch. Is it okay? Yes, thank you.
Where should I go?
Anyway, it's your show.
What did he just do to me? He took a 30-minute discussion, made it to 15 minutes, put me right before lunch when I'm starving. I don't even want to be up here right now. Please. Go ahead, you can.
Thank you, everyone. Thank you, Dr. Brian, for your...
Press the button.
Okay, thank you. Sorry. Thank you, everyone. I will not take much of your time now that it's towards lunch. My name is Edith. I work for Pact World, leading the Strategic Information Systems Management. I worked with IntraHealth International, leading the digital health, deploying and developing electronic medical records in different health facilities in Rwanda, and led digital health initiatives within the Ministry of Health. Without taking too much of your time, I'll introduce Brian. He's been introduced in the previous session. In interest of time, I won't go through that again. I'll go straight to asking Brian, how can Rwanda provide better than world-class cancer care? I would like you to talk about systems, the failure of systems, and a better way forward.
Okay.
Please.
Great.
Thank you.
Thank you. And thanks for saving the time. I have some slides that I'd like to use to support I'm talking. What I would like for this to be is just kind of a quick run through of some thoughts, some observations, and some ideas that then would start a discussion that we can have during lunch, that we can have over the next few days, and hopefully the next many years. And everything just vanished. Can we have the slides back, please? Thank you. I realize how provocative this title is. I get it. I've been here, and when I talk about better than world-class healthcare, people looks at me like, are you an idiot? My ex-wife would definitely confirm that I'm an idiot, but that's beside the point. Okay, so main takeaways. Yeah, that was a joke, and my ex-wife's son is actually sitting here, my son Casper, but that's besides the point. Okay, some things I want to get right on the table first. The healthcare systems in the high-income countries are failing miserably. The U.S. healthcare system's falling apart. It's a disaster. Most European healthcare systems are a complete shipwreck. There are isolated pockets of excellence, but as a system, as national systems, they're just dying and they will implode. Cancer care is changing in how everything from the diagnostics on to the therapeutics. There are many new technologies as well as methods that are available. However, this is not going to be a talk about cool new technologies, but the interesting takeaway is even though there are many new technologies and methods, the systems in the higher income countries cannot adopt them because of their legacy infrastructure. So there are great new ways of doing things, except, well, they're just not doing it. For example, using AI models for radiology diagnostics. We've been able to do this for 10 years, definitely for 5 years. Zebra Technologies out of Israel has had workable models for years. Been applying for US FDA approval and never getting it because there's 33,000 highly paid radiologists in the US who are members of the American Medical Association, right? So this is important. Countries that have a blank slate, a green field, can create better. That's the foundation method. System thinking is the way forward. And how do I go to the next slide? Quick little history lesson. This is London back in 1854. There was a massive cholera outbreak. Many of you have probably seen this exact study, those of you that were public health people. It was believed that the cause of the cholera spreading was due to bad air, that it was a particulate matter floating around in the air. However, it was found that it was not bad air, that it was actually due to where do I point this thing to make it work? To a water pump where there was, in the water supply, was the source of cholera spreading. And that was pretty much the beginning of epidemiological studies, public health, because what we have learned, if I was to ask you what has contributed more to the health of the public globally throughout history, it hasn't been a pill. It's not penicillin, right? It's not an antibiotic. It's no kind of a medication. It's not a surgical procedure or surgical procedures. To my friends at Electa, sorry, but it wasn't a piece of big, expensive medical equipment, and it's certainly not a fancy, famous hospital. What has contributed the most, hands down, without question, to the health of the people has been sanitation and access to potable water. It was done by engineers, like the one sitting right here next to me, right? Creating systems. This is the US healthcare system. As I said earlier, it's failing. Now you can, maybe I'm being hyperbolic or melodramatic or whatever it is. It is unsustainably expensive. No one challenges that in any way. The population is aging. It will get even worse. What you may not know is that 66.5% of all personal bankruptcies in the US are directly attributable to medical expenses. So yeah, you can get access to that great care, and then you will file personal bankruptcy. There are hospitals costing to be built well over $1 billion, with several of them being $2 billion and $3 billion. This is simply ridiculous. There is no need on earth for a $2 or $3 billion hospital. And these happen to mostly be with not-for-profit organizations for tax reasons. They're unsafe. I know it sounds horrible hearing these things, and you hear an American bashing the American system, but this is all researchable. It's estimated that the third leading cause of death is hospital-related errors. These are systems errors in hospitals. It's not doctors making a boo-boo. These are systems errors in hospitals that are avoidably killing people. It's estimated 5 times those numbers are avoidable injuries and lifetime disabilities. This does not sound like a great system to me. Life expectancy in the US is declining. Good healthcare system. Doctors and nurses are killing themselves. The suicide rate among healthcare workers in the US has been increasing for years. 20% of doctors are considered leaving practice, and 40% of nurses just getting out. They're just tired of it. Every physician friend I have in the US is pissed off. Not the kind of place I want to work, and certainly not a healthy system. There's been a nonstop increase in the closure of healthcare facilities in rural areas. Lack of healthcare services in rural areas. It sounds like I'm talking about Rwanda. No, actually, that's not true, because I've been around the rural areas, and there's some really great rural healthcare services, better than rural US. So when I'm talking about failing systems, this is what I'm talking about. Globally, we did some research on building new hospitals, because this is something where we all want help with. We all want these really smart people to come teach us how to build hospitals, because we don't know how to build anything. This is a subset of a larger study of major new hospital projects around the world. On average, 118.36% over budget, including that brand new Karolinska Hospital in Sweden. What a monster. With an average delay of 3 years, with some of the projects being delayed as much as 10 years. The systems problems, it's not just about cost and safety and other things, they're also missing opportunities to do things. I'll just give a couple, just real quick, because I know we've got to burn through this faster. Regarding cancer, I did a project with Mayo Clinic a few years ago in Dubai. It was a partnership thing. And we were looking at systemic therapies, immunotherapies, chemo and everything, asking what percentage of all of your systemic therapies could be provided in the home? Because they can be provided in the home. Mayo told me that in the US, 5% of our systemic therapies are provided in the home. I said, oh, wow, I would have thought it would have been more than that. But then we went on, but I went back to it and I said, I have a question. You're only doing 5% in the home. I said, is that the most that could be done in the home? They said, oh, no. We could do clinically safe, better outcomes, 30%, 40% of systemic therapy. They're not reimbursed by the insurance company. System failure, right? They have the provider that could provide it in the home, but the insurance company's not reimbursing because the regulator, these are all your component parts, hasn't yet approved it. White blood cell, where'd it go? White blood cell count monitoring for neutropenia. I always say that wrong. Someone here knows how to say it properly. You can now do self-administered white blood cell testing in the home with some relatively inexpensive technologies. Okay, it would save money. It would be better for patients. It's really wonderful, except it's not happening hardly anywhere because it's not reimbursed by the insurance company. It would save the system money, but the system's broken, so it's not happening. I'll speed up a little bit. This clicker's killing me. Digital transformations, they fail. We can talk about that tomorrow. This is a good article about a friend of mine, Gil. Like, everyone knows the ecosystem's fragmented and broken, but no one's doing anything about it. Donald Trump's not going to do anything about it. I mean, you know, why? Why is that happening? Because a system is components of subsystems and more subsystems. For a system to be effective, all of the subsystems, the goals of the subsystems must be aligned and supporting the main system. That is not happening in the US and in most of the healthcare systems around the world. Their systems are failing. Please do not copy them. You guys have sort of a blank slate. I know it's not completely blank, but you don't have to unwind a monster like the NHS in the US. So use that opportunity. It's not a curse. Not having is actually a blessing. I spoke in Mekelle in Ethiopia 10 years ago when I was working on a project there, a subspecialty radiology training program. And I got up in front of everyone and talked about how lucky they were. And they looked at me like I was a nut. They're like, you're from the US, you're lucky. We're not. I was like, and I said that the problem, and I said it exactly this way. You should have seen the look on their face. And I have some Ethiopian friends here, so I can say this. I said, the problem with you Ethiopians is that you're Ethiopian. And you should look, what? You can't talk like that. What do you mean? And I said, it's the same problem that me Baltimoreans have because I'm Baltimorean. I grew up in Baltimore. I was born in Baltimore. In my mind, Baltimore's always going to be the same way it always was. Right? I'm stuck in that paradigm because and when that's but it's not. It's not today. It's changed in the 30 years since I left, but not up here. And the same thing when I look at Ethiopia or I look at Rwanda, and I'm talking to people from here that maybe you're stuck in that same, this is the way it's always been. But I don't see that. I see that, right? I see it as an opportunity and potential to create better healthcare systems and possibly some of the best healthcare systems on earth. But I do know that if they're not planned, monitored, and managed, they will fail. All of them always will fail. Unbreaking a broken system, it's like trying to fix the traffic in Bangkok. You can't. Doesn't work. Doesn't happen. Providing better cancer care will not be found in a pill, a scalpel, machine, or a building. It will be by building a national healthcare system. And that was the gentleman from Partners. He used the word system at least 10 times, right? But we hear about so many other words, strategy and plan and policy and all these other things. The word is systems. Cancer care is changing. The old cancer care in big hospitals, reactive, normally late stage, all about cutting and burning and poisoning. More of an impersonal shotgun approach that really wasn't very effective, very transactional. Come in for your surgery, come in for your radiation treatment, get your injection of your hormone therapy and go home. New cancer. Hospitals should be smaller. Should be much, much smaller. Care should be out of the hospitals, into outpatient settings. Over 60% of cancer surgeries can be performed in an outpatient setting. Cancer care, when I was planning my last cancer hospital in the UAE, people would say, Brian, what are you working on now? I said, I'm building a home care company. They're like, you're building a home care? I thought you're building a hospital. Yeah. There's going to be a little box of beds somewhere, but there's going to be a really cool outpatient center, and there's going to be advanced care in the home. And that's where most of the care will be delivered, right? Got to get my palliative care friend over there. More predictive, and I'll explain what I mean by avoiding in 1 second, but it's tied to Jerry's mentioning about pharmacogenomics, precision, and about relationships. Cancer, you don't get cured. It's not a cure. So it's not a transaction. So when someone gets cancer, they got cancer unless they pass away. I can say that from personal experience. The majority of cancer care should be outpatient and in the home. And it needs to be developed at a national systems manner. Really quickly about systems in general, everything is systems. The planet Earth is a system of systems of systems of systems. The human body, system of systems of systems and subsystems. An organ within the body. Who knows what this is? What organ in the body is this? No, it's a prostate. Whose prostate is it? It's my prostate, except it's no longer my prostate because they took it out because I had prostate cancer. So I'm speaking to you as a patient, and I'm feeling fine, by the way. Thank you. Already beat on this system of systems. You got that part. Okay, take a picture of this one. This is, if there's going to be a national cancer system, and I've done a little bit of research, Rwanda's already doing a lot of this stuff. A lot of the pieces are already in place and going forward, so I'm just kind of preaching to the converted saying, keep going. The goal of all the subsystems, all the subsystem goals need to be aligned with each other, so horizontally and vertically, and they all need to support the mission of the main system. Number 4, this must happen at inception, by design, intentionally. If you allow for your system to grow organically, you'll get America. You'll get the traffic in Bangkok. Right? And unwinding and organically and grown disaster normally never happens. Must be mandated, enforced, and incentivized. I know right now there's undercapacity. So there's a desire to, let's do more hospitals, let's have more of everything. Granted. However, I highly recommend that there's consideration for something called a certificate of need, where no one can open a new healthcare facility unless there is a demonstrated need for it, that this is actually a government regulation. Right now, there'll always be need, so everyone will get approved. However, in some geographies, when you start reaching supply-demand balance, it should stop. People should not be allowed to build more facilities. The reason being is once supply crosses over demand, not only do the facilities start losing money, which, what do you care about if some private place loses money? They become unsafe. I have a whole presentation about why they become unsafe. So it's not just like, because you go to Dubai, the average private healthcare facility is only 47% utilized. They are dangerous. And also when they're losing money, what's happening? They're not paying their staff. They have high staff turnover, makes it even more unsafe. So certificate of need, good idea. Set the policy now so that later on you don't have a big political battle about the thing. National Cancer System. While a hospital is certainly a system of many systems, a hospital is only one element of a national cancer system. Don't be obsessed with how many beds do we have in Rwanda, because cancer care is not about beds, right? You know, what kind of cancer system do we have? I made this cool picture on Dali, right? I've got like an orchestra, all the different pieces in the hills of Rwanda. I just patting myself on the back. I kind of liked it. Okay, here's your building blocks. This is not all of them. This is most of them. You've got the regulator starting it, the payer, the provider, medical education, especially here, right, where you need to build up so much workforce, right? That really needs to be aligned into the system. And all the fascinating things regarding task shifting and how all that can happen, which is really important. Research, and then bringing industry into it as well. Under the provider side, you've got the hospitals, of course, but then the outpatient centers and the home care. So if you were going to build a national healthcare system, right, back to the international partners and collaborations question, who would you call? Who would you call to help you build? Well, MD Anderson, right? They're one of the best cancer people on earth. Or Johns Hopkins, where I used to work, or Mayo Clinic, according to Newsweek, the best hospital on earth. Except none of them have ever built a national healthcare system. And they work within a healthcare system that is dysfunctional. So my recommendation, take it for what you would, is I would contact, where'd it go? Here, come back. I would contact the MIT Systems Dynamics Group, because that's what they do. They help organizations and countries and governments build effective systems. Take a picture of this one. In Norway, in August, they're having their annual conference. They've been doing this for 40-some years. It is also virtual. And the executive director has already said that she would be willing to sponsor some people going to it as well. These people think systems. This is super, super important. And plus, it's beautiful there. I just went there with my wife for the first time. Love it. It's great. Okay, cancer medications are expensive. They're too expensive. They're horribly expensive. And we can't really do anything to reduce the cost of them yet. That will happen. So we need to avoid taking them. Now, but I don't mean don't take your medicines. I mean early detection, right? So we don't end up at the stage where we need to take them. Or, and by early detection, either by AI models, which I'll talk about briefly, or liquid biopsies, which we're making, but then also specifically regarding pharmacogenomics. Many, many times the medications that we're giving to patients have no effect or do not have the desired effect simply because it does not match the genetic profile of the tumor or of the individual. We're just throwing money away, $100,000 immunotherapies that did nothing at all. New AI tools, and there's a lot of them. This is not a tech talk, But they're like new, and you're seeing it all every day, new AI tools that are allowing us to detect cancers far, far, far earlier. And it's, and these tools they're the worst they're ever going to be now. 2, 3, 5, 10 years from now, they're going to be even better. This one is predicting future pancreatic cancer 3 years in advance. This one killed my grandmother. You know how we diagnosed her? I was sitting at lunch, and my dentist friend, George, after lunch, he said to me, "Your grandmother's got pancreatic cancer." And I was like, "How do you know my grandmother's got pancreatic cancer?" He said, "Because her eyes are jaundiced." She died like 6 months later, right? 3 years earlier. There's another AI, Sybil, that can predict the risk of developing lung cancer 6 years earlier. These things are real and now. This is the one that I think is really, really cool, because all that junk in our genome that they said that we didn't really know it was there for, well, we still don't know exactly what it's there for, the non-coding parts. But we're finding out that when someone has cancer, this dark matter in our DNA changes. And it's one of the first things to change before there's ever any signs or symptoms. So as part of a national screening program, you could theoretically be detecting cancers 5, 7 years before they actually present. Liquid biopsies, that's basically the cancer test from a blood drop that's actually not the Theranos scam, but is actually becoming real now. And we're running out of time. Quick word on hospitals. In general, we build them wrong. We all do. They're not hotels, really. I mean, this list that I mentioned to you, these are all big names. If you go through here, University Hospital, Whipps Crossing, UK, 200 million over budget. I mean, we screw it up on a regular basis because we're in such a hurry. We're in, and I was going to mention this when we were talking about the international affiliations. We're in such a hurry to sign the MOU and to do the, or also when we're doing these hospitals, we're in such a hurry to get the shovel in the ground. We're in such a hurry to cut the ribbon. We're in such a hurry to make my boss happy that we're moving forward, that the amount of time that goes into the upfront planning is hardly anything. Now, you're designing an organization. You're designing a system, right, that is supposed to be a high reliability organization, just like a nuclear power plant, right? Just like a rocket that's going to be taking people. So hospitals have hundreds of thousands of interrelated processes. Hotels don't. They have hundreds of different technologies that need to integrate and play well with each other. All of that should be planned out before you ever design the exoskeleton of the facility. That rarely ever happens. We need to treat this many people, we need this many square meters, we're going to draw some pretty pictures, and they start constructing it, and they develop all the policies and the systems and all that later. And we end up with all the operational problems we have, the high-risk organizations, the inability to do things, that we simply do not do planning and design of our hospital. This is a global problem. This is not any one place. It's kind of all over the place. I just mentioned this, so I'll skip that part. So this is one of the things I'm proudest of in my professional. I'm most proud of the things I haven't done. When I first went to the United Arab Emirates 16 years ago with Johns Hopkins, I was responsible for all the government hospitals in Abu Dhabi. On my portfolio was a mandate to build a 1,500-bed replacement hospital for Tawam Hospital. I had never built a 1,500 anything. It was going to look so good on my CV. Except there was one problem. It wasn't needed. When I did the analysis, they didn't even need a 500-bed replacement hospital. So this is a letter of reference from the then CEO of the government authority, right, thanking me for telling them to not build the 1,500 bed hospital because today, if they had, it would be empty. We tend to overbuild. A couple years ago, I was in Kuwait doing a hospital turnaround. Then I got asked to move back to Dubai by His Highness's office to build a new cancer hospital in the name of his late brother, Sheikh Hamdan bin Rashid Al Maktoum. Well, it's an honor. You know, I mean, I was honored to be chosen to do that high-profile project, and it was a 250-bed cancer hospital. So there I am. They had already decided it's going to be a 250-bed cancer hospital, and I show up, and I'm Mr. Home Care. I'm Mr. Outpatient. I'm Mr. Dana-Farber is only 30 beds. The average cancer hospital in the U.S. is less than 100 beds. Right? Cancer hospitals are small. They're not large. And they want to build it. This is a monstrosity, right? So I had to go to His Highness's office and say, you know that hospital you want me to build for your dead brother, I want to make it smaller. You know, everything's big in Dubai, right? The Burj Khalifa. And so now I want to build a small hospital. I had to threaten to quit. I did. I had to threaten to quit. The battles back and forth and everything. Finally, I won. In February, it broke ground. This is the Hamdan bin Rashid Cancer Hospital. Reduction of size by 54% from 250 beds down to 116. So many times or sometimes it's not what you do, it's what you choose not to do. And taking the time to plan things properly, you know, and especially as you're building a cancer system here, you will be building cancer facilities. Plan them, put the upfront planning time in. Don't build a cancer hospital, build a system. Workforce, we're running out of time, right? Yeah, you guys are starving. We could talk about this at some other time. Workforce is a big issue. You guys know your challenge here. I don't need to tell you what you already know. This is interesting. This French guy did the math that given population growth and all the things here, given the fact that you have 2% of the world's doctors, that if you try to produce healthcare workers in the same way that it's always been done, it is going to take 300 years for supply and demand to match up. Now, you know, fortunately, you're not going to do it the way we've always done it because you're going to remember the earlier slide that said, do not copy their systems. And you'll develop cool new ways like, the healthcare advisors, you know, task shifting, doing all those other innovative things. I was asked right at the start of COVID by the UAE Ministry of Foreign Affairs and International Cooperation to develop a workforce capacity building program for Sierra Leone and Liberia. I'm just going to give you a quick glimpse of it. Again, you're not going to be surprised that it was very systems-based, the top part being using platform technologies to optimize the limited workforce. Oh, you're a digital health person. Yeah, you're all about this. To optimize the limited workforce that they do have, supplement that with artificial intelligence, proven real artificial intelligence that can fill in any gaps. If and only when necessary, bring in external support, for example, teleradiology from India, but only temporarily, right? We don't want to be digitally colonized. We want to fill gaps and provide need for filling patients. The big one being education, lots of innovative education programs, distance learning, telelearning programs, lots and lots of task shifting, setting up mobile care programs and telemedicine. So this was that program. How do I get to the next slide? Good. And in almost closing, recommended reading 3 of my favorite books on systems stuff. The Fifth Discipline was written by Peter Senge years ago. That's what kind of got me hooked on the systems thing. The other 2 books are relatively new. If any of this interested you at all, I would recommend this and also checking out that conference in Europe. In closing, Marie died 23 years ago because of system failures at St. Joseph's Hospital in the US. She was in for open heart surgery. The surgeon did a fantastic job. He did nothing wrong at all. When he went to restart my mother's heart, It didn't restart. They needed to do a mitral valve replacement. He looked at the charge nurse for her to get the mitral valve from the materials department, and what? Yeah, and it wasn't there. Yeah, and she died. So systems failure in a U.S. hospital that got me becoming a systems and operations freak. Fortunately, 10 days later, I had a blessing in my life, and that was the birth of my son, Casper. Say hi, Casper. Good. That's all I got. Thank you all. Sorry for keeping you from lunch. Thank you.
Thank you very much, Brian, for a great talk. Rwanda is trying to also digitize its space. We are currently working on health information exchange, trying to make sure that there is a client registry. All the patients are registered with a unique patient ID, and you're able to locate a patient whenever they move from one facility to the other. And the other challenge I want to talk about is the shared health record, or to enable patient roaming. Today, one of the challenges we're facing, if a patient is found out with cancer at Kanombe Hospital, and that patient is transferred to Butaro, I don't think that the providers at Butaro Hospital will be able to even know that these are the basic, these are the patient history of what has been done, the basics. They'll have to redo whatever that was being done, and that is cost for the patient, and that is time for the patient, and that is pain to the patient. And the other thing is on the terminology services of medical procedures and medical products. Also, the even naming of medical products, you find that a patient will be given an antibiotic 3 times, prescribed 3 times, because it has just different naming in different hospitals. And these are the key challenges of system failures. Yes. I would like to ask you, what do you think are the most important steps to be taken? What could go wrong?
Got it, yeah. The most important immediate steps, and you're really fortunate that you have really strong leadership, right? That's, if you had really weak leadership like, well, the U.S., then, did I say that out loud? No, but no, you have, and this is my 3rd time here. I've been here, and I came here the first time at the invitation, actually, of the Electa Foundation about the cervical cancer screening program. The people, like everyone, is so switched on about doing better, doing better, but not just about me doing better personally, so I can get as the country doing better, and not just copying and pasting. So you've already got some of the things that I would say. Well, you got to get these things. You've got that. It would be getting systems thinking into the dialogue. Right, instead of we need to build a cancer hospital, or we need to in my ideal world, like if I could wave the magic wand and there would be a workforce set up, and maybe it already is. I'm not making the assumption it's not there. That here's the workforce for developing the Rwandan National Cancer System, and on that workforce, is someone really important from the regulator and someone really important from the payers, and that it's mandated that they're going to play well together, and that the people up on high are going to kick their butts if they don't, because things like standard nomenclature for medications, right? That shouldn't be up to someone's decision. Well, at my hospital, I do this, and no, someone up on high said, this is what you're going to do, right? Because we can't have committees making decisions for 7 years, about these kind of things. So getting systems, getting it into discussion, getting a group of people and go to Norway for that thing, or attend it online, or both.
Thank you, Brian. One of the things you promoted was home care.
Yes.
Do you think African homes, or even Dubai homes or US homes, are ready with the right gadgets to do the cancer management and follow-up and all that? And lastly, you live in Dubai. I would like to know if you would be feeling, or wanting to relocating or to moving to Rwanda? That would be your last question.
Okay. The first question about home care. Yeah, obviously, levels of homes and technology and connectivity and even having electricity varies wildly. So, yes and no. But there's already home care services being provided here. Okay, put your hand up. There's a home care person running, doing palliative care, all kinds of things in the home. So yes, and do lots more of it. Have a national home care association and make it into because it's big. It is so much care can be done in the home, so much. But if it's not part of the system, and if there's financial incentive for people to get people in the hospitals, then that's what you'll end up with. So it needs to be on a system.
Thank you, Brian.
And about moving here, it was funny. Right at the start of the program today, I was talking to some of the other visiting speakers and things who had been here a couple of times, and I came here with my wife 5 or 6 months ago, and she was born in Dubai and grew up in Dubai, and we were here a couple of days, and we were out having dinner. She's like, I could live here.
Good.
And I could too as well. You have a beautiful country, and thank you so much for having me here. Thank you.
Could we allow thank you, Brian. Could we allow 3 max questions for the audience, please? If you have burning question, time is of essence here. There's no, just one. Oh, there's no time, so we are going to take.
Meet me out there, and I'll answer. We could talk.
Yes, please. Thank you. They were not allowed to proceed.
Thank you, Edith. We are sorry. We have to go for our lunch, and we're going to have our lunch the same place where we had our coffee break. So talk with Brian was excellent. So I think I'm going to come also after this for my question. So thank you very much. Let's come back after lunch. So lunch is going to be 3 o'clock. We are back here at 3 o'clock, 3 p.m. Thank you. 3 p.m., sorry. It's already 14. 3 p.m.
I know.
And allow me to welcome the panelists. We are going to have two that are going to join us virtually, and then also their moderator. So the first one to join us on stage is Mrs. Vestine Mukeshimana. And then the second one is Mr. Eugene Dusingizumuremyi. So Mrs. Vestine is from WaterAid, and Mr. Eugene is from Water for People. Then we have, virtually, we have Dr. O.M. Prasad Gautam from WaterAid UK. Then we have Mrs. Sibyl Bellamy from Ketogenic. So allow me to welcome Mrs. Marie Nikes Ugabinema from Care International, who is going to be the moderator for our panel. You're welcome.
How are you? Happy? Energetic? I think it's not easy sometimes in the afternoon, but I want just to ensure that this session is going to be great. Great. Because it's one of the unusual topics that you do discuss in the cancer forums. So I humbly invite all of you to be attentive. Myself, I will be your moderator. My name is Marie Nikes Ugabinema, and I'm a public health and a clinical expert with over than 17 years experience in implementing WASH, TB, HIV, maternal child health, nutrition, equity and inclusion initiatives, programs and approach with international organizations. And I have collaborated mainly with government and UN agencies, and to name just a few. So today I'm with 4 great presenters, and I'm humbled to be the moderator today. And without further ado, I want to introduce by saying that what if we dream a world without cancer? What if we dream a world where we not have to talk about delayed detection or care management? Only because we have invested in what matters. Our session will be around the environmental factors, role in prevention and management of cancer, and we're gonna talk mainly about water, sanitation, hygiene, and nutrition. I'm sure that most of you have an idea that environmental factors are contributing a lot in occurrence of cancer, and again, contribute a lot in terms of care management. So today, I'm with 4 great speakers. We'll have a 15-minute presentation for each one of them. And if time allows, we'll be having a moderated session, Q&A session, and then we open for the audience. Shall we? Please, please. We are in work sector. We are not used to such kind of vibes. So try to show that you are with us, right? Yes. So without further ado, allow me to call our first presenter. Our first presenter today will be Mrs. Vestine Mukeshimana, who will tell us about the role of water, sanitation, and hygiene as a care preventive measure, as a cancer preventive measure. Mukeshimana Vestine is the country director of WaterAid Rwanda since December 2022. Prior to this role, she served WaterAid Rwanda in the capacity of head of policy research and advocacy since January 2019, when she joined this organization. Since then, she played a considerable and strategic role in WASH sector policy, dialogue, and campaigns in various platforms and events fora, including participation in UN high-level political forum in 2019, Global Health Summit in 2021, in CHOGAM in 2022, Women Deliver in 2023, Iowa Conference in Kigali 2023, to name few. Before joining WaterAid, Vestine, who is also an East African Community accredited hotel assessor, spent 11 years serving the government of Rwanda in its capital city of Kigali, in its all leadership arena, from tactical operation to strategic positions. Vestine holds 2 master's degrees, one in public health and tropical medicine from Southern Medical University of China, and another in development study from Kigali Independent University, a bachelor degree with honor in environmental health sciences from the University of Rwanda, and a postgraduate certificate of governance in urban sanitation from the United Nations Institute for Training and Research, rooting her versatility in development matters. Today, the title of her presentation will be Addressing Opportunistic Infection Among Cancer Patients, the Imperative of Water, Sanitation, and Hygiene for Quality Care. Please join me to welcome Mrs. Vestine as she takes us through her presentation. Thank you.
Thank you very much. I would ask, okay. Thank you so much, moderator. Thanks, everyone. I won't delay much. My presentation is basically on water sanitation and hygiene alongside cancer management. Please move. I will stick on the nexus between infectious agents and cancer, which has been wrong recognized. Infectious disease, actually, you will all agree with us that they contribute significantly to the global burden of cancer. And from studies, it was shown that cancer patients become more susceptible to opportunistic diseases. When we look at WASH crisis, WHO report that approximately 1 in 4 healthcare facilities worldwide lack basic WASH services, while 1 in 5 lack access to sanitation services. WASH conditions, today, if we can all imagine, cancer complication and all its uncomfortability, plus poor conditions of WASH, that's the equation everyone can be able to answer. Before moving ahead, I want to just give that narrative that every healthcare should have in mind that whatever the case, we are dealing with a human being who is still alive, who is emotionally sensitive, but also who is a social being. So, hold on, please. Please move. Move again. Yes. Addressing opportunistic infections among cancer patients would not only impact on the effectiveness of the quality or effectiveness of the healthcare, but also improve the well-being in so many aspects, from the psychological satisfactory to the comfort, but also to the cost of the healthcare itself. You can imagine if there is no water at the healthcare facility, any medication being taken by contaminated water would still not be as effective as it should. But also before that, if you look at the setup we are having today, minus water, sanitation, and hygiene, they are scaring themselves, putting that limitation to even adherence to service delivery of healthcare. Please move. When we look at the cause of opportunistic diseases, there are those infections that are caused by various pathogens, such as bacteria, fungi, and viruses, that poses significant challenges to patients' health and recovery. Among other opportunistic pathogens that commonly implicated in infectious patients, we can just name Staphylococcus aureus, Pseudomonas aeruginosa, Candida species, and various viral agencies such as cytomegalovirus and herpes simplex virus, and so forth. Adequate wash is an essential component for comprehensive cancer care. And if you look at the situation we are living today, it's important in preventing these opportunistic infections among cancer patients, which is often overlooked. WaterAid in Rwanda has been trying to enter into health sector. It may sound very weird and strange having a wash in cancer, but we believe and experience we had working with the healthcare facilities that are serving around 684, almost 700,000 people with water, and worked on healthcare facilities that are serving around 59,000 with the healthcare facilities with hygiene. And we could reach, again, a number of healthcare facilities with sanitation. And the testimony shows that all these interventions are impacting far above expectations in bringing the quality of lives of the people in healthcare facilities, but also adding on the effectiveness of any kind of healthcare that is provided to these people, just to add on the satisfaction of healthcare facility patients or clients. We consider infection transmission gateway as we look at wash or inadequate provision of wash services and substandard hygiene practices in healthcare facilities, households, and other settings to contribute significantly to the transmission of infections. And the findings underscore the critical importance of integrating wash interventions into cancer care protocols to minimize the risks of opportunistic infections and enhance patient safety and well-being. Inadequate wash services in healthcare facilities are basically contributing to the spread of healthcare-associated infection, and they are also among those that are opening up for opportunistic infections among cancer patients and their service providers, considering the majority being women. Please move. Inadequate of wash also undermines the quality of care, as I previously said, and affect negatively the lives comfort and satisfaction of patients due to infections, raising the cost of treatment while also increasing morbidity and mortality rates. We believe among priorities within healthcare facilities catering for cancer should include access to clean water, proper sanitation facilities, but also comprehensive hygiene education programs that could actually cut the spread and increase of infections, in addition to the main cause of the visit of patients to the healthcare facilities. Our key recommendations is that we should consider integrating inclusive and effective hygiene behavior change into core public health programming, prioritize WASH in national development budget and plans, creating the culture of awareness, enforcing regulatory standards, and invest in research to enhance WASH interventions in cancer care, but also encourage collaboration and partnership. Finally, WaterAid believe, and we want to share this, that a healthy and dignified life imperatively needs sustainable WASH for all at the center. Let us prioritize WASH across the health sector for improved public health. Thank you very much for your attention.
Thank you very much, Mrs. Vestine. I think her presentation was easy to understand because I think the majority of people here and virtually are clinical experts. So it was easy to really relate opportunistic diseases and the role of WASH in care treatment settings. Thanks, Vestine. So we invite our next speaker. I think he's joining us virtually. Our next speaker will be Dr. Om. Dr. Om will share about WASH and disease-sensitive integrated program. Dr. Om is a public health expert and behavior change scientist with more than 21 years of work and research experiences in water, sanitation, hygiene, health, behavior change, child health, immunization, food safety, disease surveillance, and HIV/AIDS program. Dr. Om holds PhD from London School of Hygiene and Tropical Medicine in UK, and 2 master's degrees, one in public health and another one in social sciences. Dr. Om currently works at WaterAid UK as a senior WASH manager, focusing on hygiene, where he's a global lead on hygiene behavior change. Dr. Om is passionate about the role that Sustainable Behavior Change Program, plays through WASH and health program in human development, and brings his skills to the health and WASH sector to improve the health, hygiene, and well-being of the poorest and vulnerable groups in low and middle income countries. He led Cezanne Behavior Change Group as well. Please welcome Dr. Om as he's taking us through his presentation. Please, a round of applause.
Thank you very much. Thanks for that lovely introduction. I'm very thrilled and pleased to be here today. Hope you can see my presentation slides. So, good afternoon, everyone. Hope after lunch is not going to be that difficult to hear about water, sanitation, and hygiene, which is often the neglected areas of work within the public health domain, especially in cancer domain of work. First of all, thanks to the organizer for breaking these boundaries between various public health programming. In particular, inclusion of water, sanitation, and hygiene was part of the cancer conference is one of that example that you are actually bridging the gap. Thanks for doing that. Without further ado, I would like to focus my presentation on highlighting some of the environmental factors for cancer prevention and management And I'll be focusing water sanitation, hygiene, and disease-sensitive public health programming. It is needless to say that low and middle-income countries are suffering from both communicable and non-communicable disease. Around 10% of the disease burden are due to cancer globally, causing around 10 million deaths per year, which is significant, and which is more than the cumulative death that COVID-19 all of us witnessed recently has caused. 6.9 million deaths from COVID, but 10 million deaths annually from cancer, which is quite significant. And you can imagine, even during the COVID-19 period, the people with cancer were more susceptible for COVID-related mortality and infection and also the mortality. And as a human being, we have witnessed many pandemics is because virus, protozoa, bacteria were never our friends. They were always enemies. While they were always enemies, irrespective whether you are suffering from non-communicable disease, they are still into the environment. They are causing infections. So you are with cancer, but is still susceptible for this communicable disease. And we have witnessed the big pandemics globally, starting from Black Death to the cholera to swine flu, Asian flu, SARS, Ebola, and recent COVID-19 being the 7th deadliest pandemic. And any of these pandemics, as you can imagine, hygiene has always been the key line of defense for many of these pandemics. Now, coming back to the cancer, I don't need to mention much of these, but just would like to establish a link. There are common risk factors for cancer. We know that 30 to 50% of cancer could be preventable. And we know that tobacco use, alcohol consumption, unhealthy diet, physical inactivity, and air pollution are a risk factor. And we know, additionally, some of the chronic infection, for example, hepatitis B and C, and then also some types of HPV increase the risk for liver cancer as well. And we also know that 30% of the cancers are attributable to behavioral risk factor. And the factors that often miss in the discourse of the cancer domain, much of the discussion and the response, including the poor wash condition and hygiene practices. And we know these factors play a crucial role in reducing the risks for certain cancer and improve the quality of care. For example, the arsenic exposure through the drinking water and contaminated food is extremely and is strongly linked. And we have strong epidemiological evidence that arsenic exposure through drinking water and contaminated food will increase the risk for developing various types of cancer, whether this is skin cancer, lung cancer, bladder, kidney, and liver cancer. It is also estimated that over 200 million people worldwide remain exposed with arsenic every year with the substandard level of arsenic in drinking water. It's a significant problem. Wash and hygiene play a crucial role in reducing the risks for certain cancer and supporting individuals for undergoing cancer treatment. And my colleagues has mentioned that people living with cancer are at risk for developing opportunistic infection, as white blood cell, WBC, is a defense to prevent infection, and the people with cancer, they have low WBC. But then access to wash and good hygiene practices can help reduce the infection and opportunistic infection, such as diarrhea, skin disease, typhoid, waterborne, and foodborne disease. But then how could we actually address it? For example, access to wash and good hygiene practices is fundamental for service provider. Imagine a cancer patient visiting in a clinic, and service provider is offering a service. What we need? We need health workers. They should wash their hands with soap. That will reduce infection. They should wear a PPE. That will reduce another infection. They should maintain respiratory hygiene. They should also practice proper injection safety and ensure environmental cleanliness. On the other hand, more importantly, if a cancer patient, how would they cope with themselves with opportunistic infection? So they have to wash their hands with soap. They have to maintain good food hygiene to reduce foodborne infection. Also, they have to drink safe drinking water, and then also clean his skin and reduce exposure with contaminated environment to reduce those infections. At the same time, we know access to water, sanitation, hygiene are recognized as basic human rights, irrespective whether you are elderly or children, whether you are suffering with any kind of disease. As a human being, you have full rights. And having access to wash is fundamental to everyone, health, dignity, and also to the health. But unfortunately, poor wash and hygiene making people sick, keeping students or children out of school, stopping adults for going for work, putting people, especially mother, babies, and elderly at risk in hospital, but at the same time putting intuition at risk for source of infection. For example, you are going in a healthcare settings, but there is no water, sanitation, and hygiene. What happens? This health center becomes an epicenter in terms of transmitting disease. And imagine you are a cancer patient and visiting clinic, and if you are exposed with that opportunistic infection. Why? Is because as we can see, around 879 million people still do not have access to water. 1.5 billion people do not have access to sanitation. 2 billion people without basic hygiene. And in healthcare facility, around 53% healthcare facility do not have hand washing facilities globally. And lack of this was meaning it will compromise health outcome, it compromise behavior, it compromise dignity of the people, health-seeking behavior of the people will be compromised, staff motivation will go down, health-associated infection will increase, the quality of care will compromise, and the overall development in such. So why should we care about WAS then? If we don't care about WAS, if there is lack of WAS services, what happens? There is increased pneumonia, diarrhea, undernutrition, foodborne infection, neglected tropical disease, environmental enteropathy, and we have also witnessed pandemics. And majority of the time, the reality is we are making our own environment more unhygienic, and we are exposing ourselves with infections and chemicals and so forth. As we are talking, because of lack of WAS, and every 2 minutes, a single child dying from diarrhea, which is also equivalent of 2 jumbo jet planes crashing every day around the world. And imagine if 2 planes were crashing every day, what would happen? 1.6 million people died from diarrhea in 2019. And out of them, 381,000 people died, children died, and of course, the diarrhea became the second leading cause of under 5 mortality for children in 2019. If you look at the risk factor, lack of water, lack of sanitation, no access to hand washing facilities, and the vitamin A deficiency and so forth. So these are some of the risk factors, and these are equally important for people living with cancer, and including to the children. So in this case, what I would like to here highlight is how the adverse access to WAS services and behavior can actually influence health throughout the life cycle. So imagine a children living in highly contaminated environment due to lack or limited access to WAS services. What happens? They're likely to ingest contamination that lead to adverse childhood experience. That means more exposure with disease. Lack of access meaning lack of hygiene practices, more infection. And as they grow, they will also expose them into the environment, and they will adopt other health risks, health behavior, and that will actually then help, or they will be exposed with disease, including cancer. That means hospitalization. And you go hospitalize, then there is a lack of water, sanitation, hygiene services. What happens? You are then exposed with hospital-acquired infection, and also antimicrobial resistance. Of course, you can see these days, we are talking about AMR as well. And then having that hospital-acquired infections, no access to WAS, meaning opportunistic infection, disability and social problem, and early death. So basically, lack of WAS actually lead for early death, irrespective, but then also if onset of cancer and with opportunistic infection, more likely. I don't need to tell to you because all of you are working into the cancer sector. Of course, many countries would have integrated cancer strategy, and it demands awareness raising, screening, early detection, diagnosis, treatment, and living with and beyond cancer. In any of these stages, access to WAS services and hygiene practices are fundamental. Integration of WAS and hygiene behavior into this ongoing cancer prevention, treatment, and response is key. Is because access to these services actually benefits public health. For example, we know simple measure of hand washing will actually reduce the risk of endemic diarrhea by 30% to 48%. It reduce acute respiratory infection by 23%, pneumonia by 50%. It reduced significantly hospital-acquired infections, Also, infant-related deaths. Diarrhea, 70% of diarrheal episodes in low-income settings are foodborne, and consumption of safe water will reduce diarrhea by 15%. Sanitation will lower the risks of diarrhea by 17%. Not only did this, having access and practicing also help reduce the transmission of disease outbreaks. So much of public health benefits here. Also, making WAS or hygiene part of the wider development agenda is a cost-effective way of reducing the disease burden, and it helps achieving the multiple sustainable development agenda. Hygiene is cost-effective. It doesn't mean that it's low cost. In order to achieve universal hand hygiene, for example, it will cost us 11 billion, particularly in low-income countries, 49 low-income countries. Similarly, having WAS in healthcare facility will cost us 9.6, basic WAS services will cost us 9.6 billion US dollar if we need to achieve universal WAS into healthcare settings. So far, what have we learned? Of course, there is a problem, there is a solution as well. And also, we also witness that most of the health sector programming are vertical. They're not talking each other. They are creating walls in between. So therefore, into the sector, there is a more demand for public health, more integrated public health programming. As you can witness, the WAS in healthcare facility global action plan urges for WAS intervention. Nutrition sector urges for nutrition sensitive intervention, which is WAS. WAS and NTD global guideline also urges for integrated programming. Similarly to the cholera roadmap, to the AMR guidelines, to the trachoma, to the immunization, all of these intervention demand for integrated programming, because we know that WAS is fundamental, is foundation for any development work, and it will help achieving multiple health outcomes. And as actors into the sector, while health sector demands for more integrated programming, WaterAid, you heard this morning with our colleagues, Maurice, he might have said to you that WaterAid will focus on water sanitation hygiene. But then we, in our strategic aim, we also focus on improve WAS, improve public health. In order to improve public health, we also focus on WAS, primarily advocate working with health sector to prioritize WAS within the public health domain. So what we do through our WAS in public health initiative is we work with the government to we offer technical support for government to develop national standards on WAS in healthcare facility or any national standards for WAS hygiene behavior change. But at the same time, we help modeling WAS services in a healthcare facility. What does that look like in reality? Installation of inclusive toilet, drinking water treatment, hand washing facilities at the entrance in each point of care, waste management, and similarly also hygiene behavior change program targeting to the healthcare workers and also to the clients. So this is how we actually then facilitate, model the WAS programming and let the government then scaling up in wider domain. At the same time, there are very limited integrated programming between WAS and cancer. But we do have WaterAid, we have designed behavior center design campaign in order to increase the behavior change among different populations, health workers, the school teachers, school students, community people. So we have designed 17 different hygiene behavior change campaign all across many countries. And one of them, for example, I just would like to highlight one of them because otherwise I will not have time. So one of them is integrated campaign, Ideal Family Campaign in Nepal, where we have integrated hygiene into existing routine immunization program. Here we are talking about integrating WAS into cancer. Since we don't have that examples globally, what I want to bring here is an example of how could we integrate WAS into existing public health programs so that we can learn and we can also see how it is feasible to integrate WAS into cancer. For example, hygiene integration into routine immunization program. Why? Because many countries were introducing a rotavirus vaccine, and rotavirus is just 1/3 of the overall diarrhea. Even if they vaccinate, it will only protect 30% of the overall diarrhea. People still need to practice the WAS behavior, hand washing behavior. So therefore, in partnership with the government of Nepal, we then set up this project to improve behavior, strengthen immunization system, and transforming public health programs the way they were currently using in order to expose mother or a guardian with the young children when they go for vaccination, exposing them with the key hygiene behaviors. This program was implemented in 4 districts initially, and we have measured the outcomes. And since this integrated programming demonstrated mutual benefit for increasing behavior, but also then increasing immunization, and government decided to then implement at national scale in 2020. So we started with 4 districts, 35,000 mothers, young children receiving behavior change campaign, part of the immunization, and now this is happening at national scale. And it is possible, and it is demonstrating a huge impact. So how it works, for example, someone visiting to the clinic to vaccinate their children, and they will be exposed with hygiene behavior change session. And we can learn a lot from this particular initiative, how we can also integrate WAS into cancer programming. Let me show you one video, just very quickly, that will demonstrate how that program actually worked.
This is Pramila and her son Mani. Pramila has been taking Mani to the health clinic in her local village in Nepal for vaccinations. At the same time, she's been learning about the importance of good hygiene. She washes her hands before feeding Mani and makes sure she properly reheats food. In Nepal, more than half of the population do not have access to a decent toilet.
That was 2015, but
More
now
than
the next is clear as
1,200
well,
children died from diarrhea in 2015. But things are beginning to change. The government of Nepal is integrating hygiene promotion into its routine immunization program. Female community health volunteers are empowering new parents to use good hygiene practices. This means the government can accelerate improvements in child health, reduce healthcare costs, and strengthen their economy for the future. Through an integrated approach, we can create a positive cycle for children like Mani so they can grow up strong and healthy and fulfill their potential. Act now. Coordinate, integrate, invest.
So this was one of the example of the integrated programming, for example. The second example that I would like to highlight, at the beginning of the COVID pandemic, WaterAid made a decision to respond COVID-19, putting hygiene as key line of defense to COVID-19. And we have operated in 26 countries, and we have positioned hygiene to respond to COVID-19. Through our hygiene behavior change program, we have raised 242 million population, more than 80 times. We have also installed more than 3,000 public hand washing facilities. We have put visual cues, nudges, and reminders to reinforce the behavior, and also distributed 2 million products, hygiene products. We supported sector coordination mechanism, contributed through WAS and health clusters, and collaborated through various platforms. And these are some of the examples of integrated programming. WaterAid cares about how we make sure that we model behavior change program, we model WAS services, supporting to the national ministry, the national government, and the national ministry. Then, because we partner, we try to build the system, we try to build the capacity, and let the government then scale up at wider scale. And finally, just to conclude my presentation, of course, the WAS into cancer becomes a new areas for investment. It is a new opportunity. So some of my recommendation based on the learning and based on the WaterAid experience. So we should focus on science and disease sensitive programming. So if we decide, for example, PX country decide integrating WAS into, let's say, ongoing cancer response or treatment response programming, what should we do? We should target disease sensitive behavior. So that means target cancer risk factor, part of your awareness raising or prevention program, but at the same time also include key hygiene behaviors so that they are not exposed with the opportunistic infection. And we need to ensure the robust behavior change program and access to inclusive WAS services. That is first. Second, we should implement an integrated programming. So we should focus on integrating WAS or hygiene into ongoing cancer awareness, prevention, treatment, and response program and policies. And that will actually help to reduce the opportunistic infection. And it will definitely, but it has to demonstrate the mutual benefit for both cancer program and also to the behavior change program. We can strengthen the coordination, and the government leadership is vital. The government leadership is vital for large-scale programming. Government only has the capacity, by the way. So many donors will come with funding, for example, or the technical partner will for technical support. And government only has the mandate, accountability, and also the mechanism to implement at scale. The government leadership is vital, and cross-sectoral coordination is vital if we are integrating WAS and into cancer or in health. Government should make policy decisions for scaling up. At the same time, any campaign that we integrate should strengthen system. And I like one of your colleagues, one of you, the speaker presenting before this session think about system. Without strengthening system, building capacity, having financing, coordination mechanism, everything will be failed. So then the other areas for investment would be on building that public-private partnership. So building that long-term partnership for WAS product and innovation and scale implementation. And finally, we should be thinking big and acting fast. Colleagues, 10 million deaths per year is not a small amount of loss. And more than that, there is there is other infections, and there is other quality of life and all sorts. So we should definitely focus on deepening sectoral capacity to drive large-scale behavior change program, large-scale cancer prevention program that integrate WAS and behavior change program, and scale implementation is vital. And we should push that. And 2030 is just there. And we should achieve universal WAS, but at the same time, we should also achieve the health agenda in order to prevent death preventable death and unwanted loss into the sector. So I will stop here because of time, and thank you very much for listening me, and happy to answer some of the questions later. Thank you. Thank you. Back to you. Back to you in the States, please.
Thank you very much, Dr. That was a wow presentation, a very inspiring and demonstrating key examples of how WASH can be integrated with other sectors, and why not WASH and cancer integrated programs. This is one of the questions we're going to take. And as he said, let's continuously take note of questions. We will be given time to ask questions to our presenters. So our next presenter will be Mr. Eugene. And Mr. Eugene will be telling us about the role of water, specifically in cancer prevention. Eugene is the country director of WaterAid, and he earned Water for People, I'm sorry. So Eugene earned an international master's in environmental sciences from the University of Greenwich and a bachelor degree in civil engineering and technology at the University of Rwanda, College of Science and Technology. After university, he worked with the University of Rwanda and the Rwanda Ministry of Infrastructure as a university professor and project manager, respectively. Eugene is also a 2021 Global Engineering Award winner, and he joined Water for People in 2012 as a project manager for Rwanda Rulindo Challenge program before transitioning over to a program manager position and ultimately his role as Rwanda country director. Please join me to welcome Mr. Eugene as he takes us through his presentation. Thank you.
Thank you, Nikes, for the long presentations. Good afternoon, everyone. I'm not sure who is the energizer today. I can see some of you are sleeping a little bit. I have been a teacher. Can you stand up and stretch a little bit? Yeah, you can just do this, maybe do this. Yeah. Those who did maybe yoga a little bit. Great, maybe we can sit and then listen. It will be the same thing. I will try not to repeat what my colleagues from WaterAid said. We are almost doing the same thing. I heard some of you from health sector saying, why WASH practitioners in the cancer conference? Our colleague from WaterAid said it. It's really very important to have that kind of integration. There's no way we can work in isolation and actually solve the problem. We really need to have integrated solutions, integrated sharing to be able to find a sustainable solution to the problem we really have. Even the moderator doesn't know Water for People. She was confusing with WaterAid. Water for People is an international organization originating from the US. It has been here in Rwanda since 2008, but we are in 9 countries. In Africa, we are in 4 countries, so including Rwanda. So next. Yeah, this kind of integration, I really want to help you to understand about integration and WASH systems. I really like Brian, how he was really explaining the health systems. So there is no way you can solve a problem without strong systems. WASH systems are really based on almost 9 building blocks or 8 building blocks. But those building blocks are really attached to other sectors, including education system, political economy, environmental systems, health systems, and we also have what we call market systems. So you remember actually our friend from WaterAid said we really need private sector. That's why we really need market systems to ensure that the whole ecosystem is really well built. Next. So the background it's not really far away from what our colleagues from WaterAid said. Providing safe water and adequate drinking water plays an important role in health promotion and reducing environmental burden of disease. You can imagine the diseases we are really facing every day. They're related to hygiene, poor sanitation, and when you might have even safe drinking water, if you really don't have adequate or you don't have sanitation facilities, your water would be contaminated. So that's why it's really very important to have all those components. Yeah, looking at now different environmental factors. You might know in your sciences back in chemistry, the heavy metals you have learned so many times. These are the bad chemicals can harm actually your organism. They can easily enter water bodies through different activities, human activities, from industries, from different sources. They can enter our water sources. When we drink those dirty water with heavy metals, so they keep accumulating in our body over time, then they posing significant health risk, including cancer. And long-term exposure to those heavy metals, especially in drinking water, we always have risk to have the different cancers like skin, lung, and kidney cancers. So that's why we really need safe drinking water, and we have to make sure that actually whatever we do, we make sure that we are really drinking safe water. So the negative effects of heavy metals. As I said, if you are really drinking water with heavy metals all the time and prolonged exposure to heavy metals, the accumulation of the heavy metals actually is really causing disease, and especially cancer. And most of them, as our colleague from WaterAid said, arsenic is one of the heavy metals that can cause a number of cancers. We also have other heavy metals, and those heavy metals, they always pose health risks, and we really need to make sure that if you are really drinking water, that water should be safe from heavy metals. That's why investment required in water can really reduce the burden on health systems. I really like the presentation of Brian. You have seen the number of doctors resigning from their jobs, the number of nurses resigning their jobs. So the main reason is that when you go to US, to Europe, so most of the other practitioners, they can take their vacation during summertime. But because they have a good number of patients suffering from different diseases, including cancer, they really don't take that. But if we can really invest in WASH, including safe water, we can use the number of patients, doctors can be relieved, nurses can be relieved, health practitioners can be released in general. That's why we really need to think big and act fast. Next. Some of the good practices we can really adopt, because sometimes we are really not sure. Most of you might be coming from Africa. You might know the scarcity of water and the quality of water we are really drinking. We always advise WASH practitioners to ensure that we have like household water treatment and safe storage. You might have safe water from the source. During the transport of that water to your tap, it can be decontaminated. You can have safe water in your tap. Your glass, your cup you're using, it can be contaminated. That's why we say to be on the safe side, to have a filter to ensure that actually you are really getting rid of those suspected actually impurities, including heavy metals, to ensure that you are really safe all the time. So drinking safe water and other safe drinks can really help you to reduce the risk of cancer. Because if you drink a lot, you can easily dilute the cancer, then you can easily urinate that and reduce the risk of getting cancer. So that's why we are really advising to drink at least a number of cups, maybe 2 liters a day, if you can, or more. That can really save your life. So prevention is really one of the pillars to avoid these diseases, especially cancer. And prevention goes with practices as well as policies and standards. You might know that actually water, they talked about lack of water in healthcare facilities. But you might know different actually chemicals you are using to treat what you are really using in the hospitals. If you might even have water, the 80% of water you are using is wastewater. So it's really very important to have that standard for drinking water, and those standards should be enforced, especially in the public water systems. Safe drinking water advisories. It's always good if health practitioners, other health sectors or other sectors like education, they can have those documents that can provide guidance to water users so that we can really avoid the use of dirty water because they are compromising our health systems. We also need clean water regulation. As I said, we have industries across the globe. Those industries, they discharge their wastewater into environment. If we don't take care, they are contaminating our water bodies. If they contaminate our water bodies, those heavy metals, they're going to be there, and we drink that water. That's why the discharge standard should be there. Again, water quality-based programs are very important to ensure that the water we are really drinking is meeting the minimum standard. I'm saying minimum standard because we can also achieve the high level standard where we can avoid that risk of contamination. Next. I'm coming back to this again. There is no way you can achieve strong wash systems without taking into consideration these building blocks. You can just move quickly next. Institutional arrangements and coordination. This is what actually our water aid friends said. We really need coordination. Not only coordinating the wash partners, but also coordinating other sectors. We have to integrate to make sure that our sector is well coordinated. So then the finance. There is no way we can achieve wash for everyone or health systems without money. Next. Then regulation, as I said, regulation and accountability is very important. It's really very important that we have those regulations, and health sector, we can really be accountable to the health sector, and you can always help to monitor if we are really providing safe water. Then we monitoring our water sources. It's very important that we know our water sources. If you remember very well, I said that human activities, other geological factors can really contaminate our water sources. It's very important that we adopt water resource management practices to make sure that we are always monitoring the quality and quantity of our water resource. Because we might even have a water source today, and due to environmental factors, climate change, that water can really disappear. That's why water resource management is very important. So learning and adaptation. This is very important for wash sector. It's also very important for health sector. We really need to learn from each other. There is no need to reinvent the wheel. So if something is happening there, we learn from that, and then we adapt. Next. Then planning. Planning is also very important to be able to have a strong system. And again, monitoring, we can move to the next. Then monitoring is also very important. There's no way you can do monitoring. If you are really planning, you make sure to have a robust monitoring process to ensure that whatever you plan, or if you are really investing something, you make sure that you are really achieving what you plan. Then service delivery infrastructure. It's the same like healthcare systems. There's no way you can provide the health service without infrastructure. The same for wash. We didn't need infrastructure to deliver the service, and those infrastructure should actually meet the quality and standards. So, and to be able to have that service every time, we really need what we call the preventive maintenance. You can imagine if you have those equipments, some of you were sharing, high quality, high tech facilities. If they really don't have preventive maintenance, they can fall apart. So in 1 or 5 years. The same for wash. We really need high quality infrastructure and preventive maintenance to ensure the forever service. Thank you.
Thank you very much, Mr. Eugene. I noted that he's from Water for People, not Water Aids. And he was joking, he's my colleague. I'm sitting in their office. So I know that from now, you know that whenever you take a bottle of water or you are washing with water, it's good for your health, but it also can be a source of cancer. Don't forget that. The same for patients you are dealing with. Whenever they are in contact with water, it can have many chemicals that can cause harms. So without further ado, let me invite our last speaker, but not least, of today, Mrs. Sibyl, who's gonna tell us about the evolution of diet and its impact on cancer metabolic strategies, ketogenic diet, and the medically validated dietary supplement of ketone body production. Sibyl Kraft-Bellamy has been an active advocate of ketogenic diet and metabolic strategies in the medical field for over 20 years. From the US to Europe, Africa, and Asia, she participates in symposiums aimed at medical practitioners as well as patients and caregivers. She is a nutritionist specializing in the management and monitoring of medical ketogenic diets for epilepsy, neurocognitive diseases, and metabolic strategies for adventure cancer therapy. She is the founder and president of Keto M+, a company specializing in the research, development, and production of ketogenic medical foods, ketogenic dietary supplements, and ketogenic staple foods. Sibyl Kraft-Bellamy will be presenting the current situation and how ketogenic diets are being used in adventure therapy for cancer patients. Please welcome Sibyl. Thank you.
Thank you very much. Is this me? Do I have to put my slide or someone is gonna integrate the slide?
You were given an access to do your own presentation. Please try.
Okay. Sorry.
If it doesn't work, someone here can help you and put it on. Yes, someone will help you and present on your behalf.
Yes, please. Sorry.
Thank you.
So thank you very much. Like you said, so I'm Sibyl Kraft-Bellamy. I'm a nutritionist and I'm specialized in ketogenic diets. If you can. Here. Thank you very much. Sorry about that. So harnessing the power of ketogenic diet, exploring new adjuvant therapies in cancer treatment and beyond, and discover the comprehensive solution offered by Keto M+. So I'm Sibyl Kraft-Bellamy and I'm the president and CEO of Keto M+, and I am a nutritionist. Can we go next? So the cancer burden is projected to rise from 1.1 million and 7 to with a raise of, I'm sorry, I have prime 2. My screen is being, oh, here we go. From 1.1 million cases and 700,011 deaths in 23 to 2.1 million cases and 1.4 million deaths in 2040. So Africa is one of the continents that we will see one major increase in deaths was induced by cancer. As you can see, the incidence of cancer is rising all around the world, specifically in area where the change was, like you were stating before, access water and nutrition are being challenged, but also because of a new arrival of a new nutrition. So specific cancer are being like leading in Africa the same way we have in Europe or in the United States, where I'm more like used to, like breast cancer, cervical cancer, or prostate cancer. And as we can see later, most of this type of cancer are hormonal dependent and can be directly triggered by increased intake of insulin. So the evolution of the African diet was noted with like an increase with high glycemic carbohydrate food products and also drink products. We do have a poor intake and deficiency in vitamin D and A, who can be also like triggering and have unfortunately a negative response in the susceptibility to develop cancer. We have a major microbiota disruption due to loss of traditional food consumption and to a new generation of food products who are extremely damaging for the microbiotes. And this impact of the Western diet is having like a triggering effect on the cancer. So cancer risk factor are coming from different kind of reason. Cancer are extremely complicated disease, but we obviously know now the environmental, the genetic, and the nutritional impact will have with a higher consumption of industrialized carbohydrate have a direct effect on the cancer and other metabolic disease. So what is a ketogenic diet? It's a high-fat, low-carbohydrates approach, food approach. We have a moderate amount of protein, and the idea is to produce ketones. You're producing ketones when your carbohydrate intake is very low, and the body is going to find another way to produce energy and shifting the metabolism toward using like insulin for now to use like fat at the main trigger, the main source of energy. So the food pyramid, as you can see, is literally almost reversed of what we have today, because the base of this pyramid will be lipid, fatty, unsaturated, saturated food products. So a lot of like seeds, oil, coconut oil, avocado, walnuts, and after that we're going to have regular protein we can find in fish, cheese, and after that a small amount of carbohydrates. The most important thing is all this carbohydrate must have what we call a low glycemic index, which means under 50, and that's where is the mostly dramatic change shift that we have today. Is today people are consuming a pretty high amount of food product to have a high carbohydrate content and not enough fiber content. So this way of feeding when you are in a ketogenic diet, you are boosting the production of ketones through the intake, the food intake of fats. And also the carbs, low carbs, like vegetables and fiber, will help to temper insulin fluctuation, which is critical in the development and some type of cancer. But this way of feeding, ketogenic diet, is also being used during the treatment of people who have regular therapy for cancer. What we want to do is to be sure that the insulin is controlled and the sugar level is stable. And we also want to have this new way of bringing energy to the cells who facilitate patients to have chemo and other treatment and keep a good level of energy through the with the ketones. So the benefit of keto diet, which is this new way of eating on cancer treatment, there are multiple ways. So we are lowering the carbohydrate intake, which means we're going to have a better control of the insulin. And again, we're not going to have this insulin fluctuation. We're increasing the calorie intake, nutrition product on keto, on ketogenic diets, like coconut oil, all this kind of fatty have really a high energy intake and nutritional interest for people who may not eat as much and have at the same time calorie intake, which is pretty high. And that does help people to avoid to lose weight. And with the appropriate amount of type of protein, we can also avoid to have sarcopenia. The challenge of this kind of diets can be the compliance, because we are reversing the normal typical way of people when they're eating, because again, we are lowering carbohydrate intake. or we're switching to another type of carbohydrate that people are not necessarily used to eat. The other challenge is the proper guidance. It is a very complex diet to start for specific cases, mostly for cancer patients, because we must be extremely careful with the type of treatment that the patient is taking and how all the side effects and the comorbidities who can go with the treatment that a patient can have, which means some patient may be vomiting or may have poor appetite. And for this type of patient, we want to be sure we personalize the diet, and we're going to keep the food product that the people may like or will discover and like. And this is really the most challenging part. So I am in the ketogenic diet field for 20 years. And we know now specific ingredient will facilitate the production of ketones. Ketones are essential in the cancer and when we are using ketogenic diets, adjuvant therapy, because they're going to help to control the proliferation of cancer cells. So if we want to boost ketones, we're going to have to use some specific ingredient who are very well known to boost ketones, and that we call MCT. That's a medium chain triglyceride that we find in coconut oil or in goat products. And this MCT, like again, they're going to boost ketones, but they are going to also regulate the macrobiote to a specific way to have to maximize the treatment that we're going to use with chemotherapy. So I developed a first product named Cetoprine. So it's a medical food. It's registered in France like a food for medical, special medical purposes. It's a product which is taste-wise very pleasant and is very easy to integrate in a recipe or drink from children to adult and senior patients. And we just have to mix this product, or we can take directly in the mouth with appropriate keto meal to boost, again, ketones production. Cetoprine can also be presented like a placebo if needed. If you want to set up a clinical study, a randomized clinical study, and you want to be sure to have different groups, we can also formulate placebo who facilitate, obviously, the clinical study. So the product is highly versatile. We can mix it in like some kind of gravy or drink or food, and again, take it directly in the mouth. Right now, Cetoprine is being used in 4 clinical studies for patients who have kidney cancer, glioblastoma, and breast cancer. So all these 3 types of cancer are obviously very different. For some cancer in France and in Europe, we are encouraging patients, mostly with glioblastoma, was a very difficult cancer to treat, to start an adjuvant therapy on the side of regular treatment for different reasons. Many glioblastoma patients that we are following have epilepsy. So as we all know, ketogenic diet first was really targeted, was very developed, and we know is extremely powerful to control epilepsy. So patients with glioblastoma and epilepsy highly benefit of a ketogenic diet, and Cetoprine is very well accepted. We also have a small clinical study was just finished, and we're going to start another larger one, randomized one, where same thing, Cetoprine was being used and extremely well accepted by patients. And for breast cancer, the women who were following the keto diet and used Cetoprine were very satisfied by the product, because it definitely helped them to keep a good nutritional intake and were able to control weight loss. We are also participating in different protocols for Alzheimer. The product is extremely well accepted by patients because it's very easy to digest. And for many patients, again, who have different kind of treatment, cancer, but also Alzheimer, where, for patients who have a lot of gastrointestinal problem and weight management, the product is well adapted to control the weight loss. So where are we at with a ketogenic diet? Today, ketogenic diet, like I said, they're extremely well accepted with epilepsy, obviously weight reduction, diabetes, because obviously we're controlling food insulin fluctuation, and cardiovascular disease, because we are increasing the ketones production, and most of it, again, we are controlling insulin balance. And we are recommending very specific fats who are very well known have benefits on the cardiovascular system. So the cancer ketogenic diet being used for adjuvant therapy with cancer is now, it's, I believe I follow patients who are maybe like in pediatric for like over 10 years. It is sometimes challenging. The biggest challenge is that we always must adapt the diet to the patient. So it's very important to respect the cultural habits of the people. You don't want to modify in a very strong way the diet, which means that if people feed a specific way, and we know that we have to modify some group because there is too much sugar, everything have to be very slowly and accepted by the patient. So we always have to find a good challenge of initiation of food and meal that the patient will accept and take on the long term. So like I was explaining, cetobran is very easy to take. You can integrate it in food. You can mix it in any kind of sauce, or you can mix it in cream or in yogurts. The formulation is very adapted, again, for the production of ketones, but it's also adapted for people who have challenge to keep weights. So we have DHA omega-3, very strong anti-inflammatory product. We have vitamin D, selenium, as you can see, coenzyme Q10, probiotic, to be sure that the people who are taking the product and also who are already like sick and have very strong medication and treatment will be able to have like the capacity to have the best well-being and avoid many side effects that can be like vomiting or diarrhea. So I created Keto Plus to provide high-quality medical ketogenic diet products for vulnerable and medically fragile people who need extra help as the ketogenic diet. The goal was to really use high-quality products and to develop different kind of products following what is available in different kind of environments. What I mean is we are developing other products with specific lipid or oil that we're going to find in geographic area that we know are the most adapted to the population because it is staple that they're used to eat in regular basis. So I create Keto Plus because I have a 22-year-old son who has a rare genetic disease with a pharmaco-resistant epilepsy. And I was highly dissatisfied by the products who were available. So I wanted to create something who was good quality with a high efficacy. And again, I wanted to be sure that I would be able to formulate products who can be adapted in every different kind of country and use the local resources and local products so we can have a product to really fit the profile of the people who will need it. So Cetopran is the first product we developed. A second product was developed, Cetohydro, and it's an electrolyte product. and it's to be taken with water to facilitate rehydration. Like you were saying before, dehydration can lead in pediatric and some very fragile, vulnerable people to major dramatic consequences. In epilepsy people, it does increase epilepsy, and for other people, we can have difficulty of like major health problem like constipation and other like again neuro disorder. We can have increase of stress, anxiety, sleeping disorder. So cetohydro is mostly a different kind of regular electrolyte like potassium, sodium, magnesium, and it boosts that quick rehydration. So we are specializing in formulating medical food. Right now we are formulating a cetohydro for infants for quick rehydration. And we are working on different kind of products adapted for senior people. And we also work with hospital and research center to understand what kind of nutrient would be the most effective, again, for some patient. So we had multiple prize in Europe, in the United States, and also in different countries. Like I said, my goal is to be sure that we can develop products who can be adapted to different environment and being the most personalized with a patient. Thank you very much. And if you have any question, I will be happy to answer you. Thank you.
Thank you very much, Sibyl. For me, I take this diet as a love mother diet because it was produced for the sake of treating her son and tested first on her child. So it can be a best of the products food supplement on the market, I think. So I'm gonna ask speakers to allow me to skip the moderated Q&A session for the sake of time. And later we're gonna take the audience questions. For anyone who has a question, please introduce yourself briefly and go straight on the point on your question and specify the speaker you want to respond to your question. So over to you. Let's be active. Yes.
Thank you. My name is Faustin Nyaneza. I'm a medical doctor. I'm very, today I'm with a pleasure to attend this meeting. So it is very productive and very informative. So my questions is directed to the both country director for Water for People as well as Water for AIDS. It's about what are currently we've seen some challenges, but maybe currently there are someone who want to help in any other area that is maybe still having a gap. So I would like to tell us what is like the current opportunities or challenges that are you still facing. Thank you.
Take like 3 questions and then I give the floor to speakers to answer your questions. Three are mandatory questions. Otherwise, I will go through the the moderated question and answers sessions. Please. Okay, let me give the floor to our speakers, country directors.
Thank you very much, Dr. Foster. It's an interesting question. What are the opportunities and challenges that exist in this area? The area is the nexus between wash and cancer. I will speak from the perspective of Rwanda context and start with opportunities. Today we have learned a lot about systems, and I completely believe that only strong system can deliver the health care and lead to the dignified lives we are all singing. In 2021, we saw the policy out in Rwanda, which is bringing this synergy of our interdependent and interrelated nature between plants, animals, and human life, which is one health policy. And I think more of these issues that are actually bringing our people and ourselves to cancer are the misconnection or disconnection between those three natural elements of the nature. When we look at pesticides that are used in agriculture, when we look at the antibiotic resistance or multi-resistance to antibiotics that are deriving from use of antibiotics in not only human medicine but also animal medicine, and also look at the technology and economic innovations that are coming with other pollutants and the lifestyle we are looking, we think if we can have proper coordination and integration, but also cross-sectoral collaboration, we can minimize the risk and only go for those that are meeting the sustainability and safety we need. So I would say that the challenge we see is that the sectors are not talking to each other. Water and sanitation and hygiene sector should talk more or more closely and better with the health sector. We need that integration. We need that togetherness. We need to plan together and consult each other as we complement each other. We need a space for WASH at the center of health sector. At WaterAid, we always say, don't call it healthcare facility if there is no water and sanitation. And we want it to remain that healthcare, having water. And the good thing is the existing finances that, for instance, in healthy, if leveraged to support improvement of water and sanitation, can bring a huge change in terms of saving money or financial savings and life saving, as well as effectiveness of the quality. So I will stop here. I know my colleague will add. Thank you so much.
Thank you so much for the good question, Dr. Foster. If you really look at actually around countries, there is opportunity of political will. If political will is there to have good policies, to favor good healthcare facilities, a good wash systems, we can live in a paradise without cancer. We can live in a paradise without those degenerative tropical diseases. So which means the political will in all the countries should be there. It's an opportunity to have good policies, regulation, and standards. Again, the challenge, you might have some goodwill, good policies. As Vestine said, the challenge of investment. So we need investment. You saw the 50 healthcare facilities, you saw how much they cost. We need that money to be invested. If you look at the money required to invest in WASH, I don't recall in 2022, WASH did what we call the WASH strategy, WASH strategy investment plans. And if you look at the investment required to achieve universality or universal access to sustainable WASH services, it's a huge. Another opportunity to break that chain or just to avoid that challenge, to overcome that challenge. So we really need what we call blended finance. So how do we bring in financial institutions? How do we bring in private sector? Not only waiting the money from the treasury, not only waiting the money from the Minister of Finance. How do we think big and act fast? So those are opportunities. Challenges are there as we are sharing, but we have a lot of opportunities and we really need to think big and act fast. Thank you.
Thank you very much. Just one last question over there.
I would like to address my question to Ms. Bellamy, and I would like to ask, most of the ketogenic diet, they normally say that it has strict requirements. So usually strict requirements comes with potential nutritional deficiencies. So how can she advise people, especially when they want to integrate ketogenic diet in their life? And another question is, are there specific individuals that ketogenic diet does not work for, since there is variability? It might work for one person and then doesn't work for another. That's it.
So for the second question, like I was explaining, the diet has to be personalized depending on the type of disease or cancer, or if different kind of cancer. We have to assess, obviously, the general health of the person. We do check some specific level of, for example, carnitine or all these kind of vitamin and other like mineral, to be sure that this person will be able to process and produce ketones in the most appropriate way. Depending on the weight, depending on the age, and depending on the way the person is handling the treatment that she's been following for cancer, we will adjust the diet regularly. For the deficiency, usually we can definitely give some multivitamin, but in general, the food is being focused on specific highly nutritious products who are rich in vitamin and mineral. The other thing is, because we are not consuming as much sugar, the oxidative stress is not as important. For some vitamin, it's easier to just have a good level with some like low carbohydrate product. I'm going to say like lemon juice or a specific like greens. Can you repeat your first question, please?
I was asking, like the advice that you can give to people who want to integrate ketogenic diet in their life, especially when it has some restrictions that can lead to potential nutritional deficiencies.
Well, there is always a way to adapt the diet. We have people who have like, if the restriction is because of taste or accessibility, we will try to find what is obviously available and can be adapted to be sure that we respect the ratio of the diet. If it's for other reason, like feeding difficulty, that's also usually pretty easy to adapt. That's to a reason. And again, it will depend of the general state of the person. And following that, we will be sure that we have the minimum nutritional intake, and be sure that we don't have any side effects like dehydration, or we want to be very careful to be sure the person is not losing weight. We want to be sure that there is no sarcopenia. So all of that, again, will be personalized with the patient. So we can use like product like mine, who are rich and in, like I was saying, MCT, but also DHA, selenium, coenzyme Q10, vitamin D, that are the first nutrient that we can be deficient when we start this diet. I don't know if I answer your question.
Yes, you have. Thank you.
Okay, please do not hesitate to contact me later if you want by email. We're more than happy to answer you.
Yeah, thank you very much. The time is not on our side. I would like just to a little bit concluding that by saying that understanding the role of environmental factors in cancer prevention and management is key. And we're given some of the great examples on how we can apply and adopt some of the WASH strategies, program approaches, and models as shared by Mr. Eugène, Dr. Om, Mrs. Vestine, and by also adopting effective lifestyle by controlling our nutrition diet and using some evidence-based diet type like the one shared by Mrs. Sibyl. The establishment of effective cancer prevention and care system should look beyond clinical services and think about also other public health interventions that can help to cut the costs injected in clinical services for care treatment. So I hope that this session was very helpful for thinking beyond just the cancer and think that cancer need more sectors to be more and cost effective. So thank you very much again for our great speakers, and thanks for the attention from our audience. Thank you.
Thank you very much.
Thank you, everyone.
Thank you. Bye-bye.
And good luck for the conference remaining.
Thank you.
Thank you very much, Mrs. Nikes and the team. So we are coming to the end of our day one of the E3 International Conference. I would like to thank all the participants and also the speakers. This has been really informative, at least for me, and I think for all of us who are here today. So at this juncture, I also want to invite all of you tomorrow. Tomorrow is going to be a very good day, a very good day. So you don't want to miss tomorrow. You're welcome, everyone. And before I conclude, we have two announcements to make. So the first one is that the management of ICAD Africa wishes to give a tour to whoever who is willing to or wishes to see the center from tomorrow, anytime. And two, there's some transport facilitation. I think some people came with this facilitation. Please, the protocol is outside there to help you. And they have different routes, and they're going to tell you which one to take depending on where you're going. So at this point, I would like to thank you all very much. A lot of information, a lot of knowledge, and good night.